of free paper session. I would like to invite our first speaker, Sayyid Muinuddin Shah, and he'll be presenting his topic of a randomized controlled trial.
Hello, Assalamu alaikum. My name is Dr. Sayyid Muinuddin Shah, and today I'll be presenting a case on efficacy of bioactive collagen versus combination of glucosamine and chondroitin sulfate in grade 1 to 3 knee osteoarthritis, a prospective randomized control study. So, global incidence of the hip and knee osteoarthritis is estimated to be 14.9 million cases per year. Conservative management strategies aim to alleviate the pain and enhance the joint function via lifestyle modifications, weight loss, analgesics, and physical therapy. Systemic slow-acting drugs of osteoarthritis has shown the delay in the disease progression and improvement in the function and pain. Out of many medications, collagen peptide, glucosamine sulfate, chondroitin sulfate has recently surged in the usage. Okay, we intend to compare the efficacy of orally administered collagen peptide versus orally administered combination of glucosamine and chondroitin sulfate in reducing the pain and stiffness and in improving the joint function and quality of the life in grade 1 to 3 symptomatic osteoarthritis over the period of 3 months. So, our study was a prospective randomized control study, and it was about of 1 year duration. Sample size were 150 patients, and it was included in the Department of Orthopaedic Liaquat National Hospital. So, we used probability stratified sampling technique, and there were 150 patients. We divided into 2 groups. Group A was given bioactive collagen, and Group B was given combination of glucosamine and chondroitin sulfate. And the follow-up was kept at the 3 months. Okay, so the measuring scores were kept, WOMAC score, health assessment score, and also Westpan scores. It's not working. Okay, so as in this graph, we can see that the both groups have shown the improvement in the measuring scales. But however, the group B has shown significant improvement which we used glucosamines and chondroitin sulfate A compared to the group A in which we use collagen peptide. Glucosamine and chondroitin provide beneficial effect on efficacy, particularly in the osteoarthritis and joint pain when glucosamine and chondroitin was used in combination rather than alone, suggesting these two ingredients have this synergistic relationship. Collagen-based supplements has a positive effect on the pain quality of life and levels some functional test results in many patients with osteoarthritis. It is the first prospective randomized control trial that we have carried out to compare the both glucosamine and chondroitin sulfate with the collagen peptide in the treatment of osteoarthritis in the Pakistan. We haven't seen any literature in the past that has compared these two medications in the efficacy, but however, individual studies have been done over the collagen peptide efficacy and also the combination of glucosamine and chondroitin sulfate. So this is the first of its kind study in the Pakistan that we have carried out. Our conclusion that this study has shown there has been improvement in the Westpan scale, WOMAC score, and as well as the patient reported outcome measurement in the both groups. However, the chondroitin sulfate and glucosamine group has the better outcome as compared to the collagen peptide group. Our limitations was small sample size, single center study, short duration, and a short follow-up. So we recommend a multicentric study with the large sample size over longer period of time will provide us the superior results which will be better applicable on the larger population.
1 minute remaining.
Thank you.
Thank you very much. In the interest of time, we won't have any questions.
Okay.
So we will move on to our next speaker, which is Dr. Rehan Ali. and he'll be presenting his paper on primary total hip arthroplasty in young patients, a short follow-up study.
Assalamu alaikum. I'm Dr. Rehan Ali, and I'm presenting my paper on primary total hip arthroplasty in young patients, a short-term follow-up study. So, the total hip arthroplasty has transformed the management of end-stage hip pathology by significantly improving pain, mobility, and quality of life. Although widely performed in the elderly population for degenerative osteoarthritis, the THA is increasingly being considered in younger patients due to conditions such as avascular necrosis, development dysplasia of hip, and the post-traumatic arthritis and inflammatory arthropathies. In Pakistan, whether it's high burden of trauma, untreated congenital disorders, and the delayed presentation to the healthcare system, the need for early hip arthroplasty in the younger population is rising. Historically, the outcome of THA in this population has been suboptimal, primarily due to increased physical activity, early and implant wear, and the surgical complexities from the prior intervention. Recent advances, including the use of cementless fixation, modular and ceramic bearing, and improved surgical techniques, have improved THA success in younger population. However, there is paucity of local literature evaluating outcomes in Pakistani population. So the objective of our study was to evaluate the short-term functional outcome, implant survival, and the complication rates of primary total hip arthroplasty in patients aged less than 50 years at the tertiary care hospital in Karachi. So this study was carried out in Liaquat National Hospital. It was a retrospective study with a 5-year follow-up, and there were 82 patients were included. The patient aged less than 50 years at the time of primary total hip arthroplasty, and the minimum post-operative follow-up of 5 years were included in the study. And the primary outcome was change in Harris hip score from baseline to 5 years, while the secondary outcomes were rate of dislocation, infection, and reoperation rates. These are the preoperative diagnosis distribution. As we can see, the avascular necrosis was the most common complication seen in these patients. These pie charts represent the bearing surfaces and the implant fixation type. The most commonly used bearing surface was metal on highly cross-linked poly, and cementless fixation was most commonly used. The preoperative mean Harris hip score was significantly improved over 5 years, as we can see in this chart. As of the post-operative complications, there were 2 dislocations which were treated initially with closed reduction, but ultimately due to recurrent instability, they were revised. And the one deep infection which was initially treated with the irrigation and debridement, but eventually it was treated with the revision surgery for persistent infection. So this is the Kaplan-Meier curve, which shows the approximate implant survival over 5 years, which is 96.7%. So this was a single centered study demonstrating excellent short-term outcomes of the primary THA performed in the patient younger than 50 years, with a minimum Harris hip score improvement from 50 to 94. Complication rates were low and comparable to those reported in the international literature. As we can see, the Harris hip score and the implant survival were compatible with our study. So the study was limited as it was a retrospective study. It was a single-centered study which reduced generalizability. The follow-up time was limited, which was 5 years, and there is small sample size. So in conclusion, primary total hip arthroplasty in patient younger than 50 years in tertiary care hospital demonstrate excellent short-term functional outcome and implant survival at 5 years. These findings align with the local clinical experience. Multi-center registries and long-term follow-up are recommended to further improve implant selection and national practice patterns. Thank you.
Thank you very much. Now I would like to invite Dr. Ahmed Sajid for presenting his paper on direct anterior versus posterolateral approach for femoral neck fractures.
Good morning. My name is M. Sajid, and I'll be presenting an updated meta-analysis comparing two different surgical approaches for total hip arthroplasty, the direct anterior approach versus the posterior lateral approach. We focused on elderly patients with femoral neck fractures. Total hip arthroplasty is one of the most common surgeries in orthopedics, with over 500,000 cases annually in the US. Elderly patients present higher surgical risks due to comorbidities and reduced physiological reserve. Our goal was to see if the approach really impacts the recovery and complication rates. This isn't working, I'm sorry. The direct anterior approach is a muscle sparing technique that often allows for quicker recovery, but it has a steep learning curve for surgeons. The posterior lateral approach is very common and provides excellent exposure, but has been linked to higher risk of dislocation. The evidence on which approach is better for this group has been inconsistent, which is why we conducted this review. We conducted a thorough, PRISMA-compliant systematic review and meta-analysis. We registered our study with Prospero and searched several major databases, including PubMed and Cochrane, up to May 2025. We included randomized controlled trials and comparative observation studies. Our study was guided by the PICO framework. The population was adults getting a primary THA. The intervention was the direct anterior approach. The comparator was the posterior lateral approach. Our outcomes included pain and functional scores, operative parameters, and complications like dislocation, infection, and nerve injury. We used a random effect model for our data analysis. For continuous data, we used the weighted mean difference. For dichotomous outcomes, we used odds ratio, and we set the statistical significance at a p-value of less than 0.05. Out of 460 papers, 94 remained after duplicates were removed. 68 articles were assessed in full, and 21 studies totaling of about 2,000 patients met our criteria. The groups were well balanced. Most studies were recent and of low risk of bias. The Harris Hip Score is a validated tool used to assess hip function, combining pain, mobility, and activity of daily lives into a scale of 0 to 100. In our analysis, the direct anterior group consistently outperformed the PLA group at 1 week, 1 month, 6 months, and 12 months. The largest improvement was at 1 month, with the DAA group scoring over 6 points higher, surpassing the threshold for clinical importance. When looking at pain using the BS scale, we found no significant differences at most time points. However, at 1 month mark, the direct anterior approach patients reported significantly less pain with a mean difference of negative 1.22. Direct anterior approach was consistently associated with a shorter incision length, less blood loss during surgery, and a shorter hospital stay. Patients also became mobile quicker, while the operative time was sometimes slightly longer with the direct anterior approach. One of our most important findings was that direct anterior approach had a significantly lower dislocation rate. We calculated that the direct approach had 71% lower odds of hip dislocation as compared to PLA patients. Other complications like fracture and infection were comparable between the two groups. It's worth noting that a temporary nerve irritation in the thigh was more common with the direct anterior approach group, but it was very self-limiting. In summary, our key findings are that the direct approach offers significantly early functional benefits and less pain in the first month. It has comparable safety profile to PLA with lower dislocation risk.
1 minute remaining.
A common complication with direct anterior approach is nerve irritation, which usually resolves itself. Based on our updated analysis, the direct anterior approach is a viable and beneficial option for elderly patients undergoing total hip replacement. It offers a quicker recovery and a similar or even better safety profile when performed by an experienced surgeon. Thank you.
Thank you very much. Now I would like to invite Dr. Faraz, and he'll be presenting his paper on two-stage revision total hip arthroplasty after PGI. Is Dr. Faraz here?
Assalamu alaikum everyone. My name is Dr. Saeed Mohammad Faraz, and today the topic of my presentation
is on two-stage revision total hip arthroplasty after prosthetic joint infection, a 10-year experience in Pakistan. So prosthetic joint infection after total hip arthroplasty is a devastating complication. It leads to implant failure with significant patient morbidity and increase in the healthcare cost. Although one-stage revision has been carried out with equally good results for PJI in the Western world, two-stage revision THA is a time-tested method for PGI in all types of infections and host. So this chart shows that due to increasing number of total hip arthroplasty in our country, there is an equal number of increasing cases of its complication, in which infection is one of the leading cause for the revision THA. So our rationale was to evaluate our 10-year experience, which will help assess the effectiveness of two-stage revision in our setting, provide guidance for the treatment planning in future PGI cases, and inform decision-making in a resource-limited healthcare system such as ours. Our study design was retrospective, and all eligible cases from the study period of 10 years duration from 2012 to 2022 in Liaquat National Hospital were accounted in it. The inclusion criteria was that patients between ages of 18 to 90 years with confirmed infection of primary THA using musculoskeletal infection societies criteria, and those who were undergoing two-stage division THA. We excluded those patients who refused to provide informed consent, who were undergoing any other associated surgery, or who were lost to follow-up during the study period. The pre-op assessment was done using functional score assessed using the modified Harris hip score. We removed the infected THA components with intraoperative cultures were obtained, and debridement of all dead, dying, and doubtful tissues were done along with copious washout. Then an antibiotic-loaded cement spacer was placed with 4 grams of vancomycin in 40 grams of cement. The post-op antibiotics were tailored according to culture sensitivity, and infectious diseases was taken on board with antibiotics given for a minimum of 6 weeks. Every 2 weeks, inflammatory markers were followed, and a downward trend was considered to be eradication of infection. The criteria for second-stage surgery to reinsert THA prosthesis were that CRP and ESR values in the normal hospital lab range with absence of clinical signs of infection, negative cultures upon joint aspiration, and antibiotics being stopped for at least 2 weeks. The patient was mobilized early as tolerated by him or her with prolonged course of antibiotics given, and patient's follow-up was scheduled at 2 weeks, 6 weeks, 12 weeks, and then yearly. Clinical assessment was done using modified Harris hip score, and clinical laboratory monitoring was done for recurrence of infection. Our total patient population was 149 patients with mean age of 57 years, and mean time to infection was 1.2 years. This chart shows the comorbidities and immunocompromised status, which shows that type 2 diabetes, hypertension, and ischemic heart disease were the leading cause of comorbidities. The average spacer retention time was 9 weeks, and recurrent infection before reimplantation was present in 8% of patients, which required repeated debridement or exchange in the cement prosthesis. For reconstruction and bone graft requirements, press fit was done in 57% of patients, which was the majority, while in other hybrid cementation and fully cementation was also done. Bone graft was also required in 35% of patients, and acetabular anti-protrusive devices was also required in 13% of patients. This pie chart shows the pathogen distribution in our population, which shows coagulase negative staph, MRSA, MRSA, and gram-negative bacilli being the leading causes of PGI. Interestingly, 14% of cases were culture-negative PGI, which were diagnosed as those who had greater than 5 neutrophils per high-powered field on histology, despite negative cultures. So this chart shows a long-term infection-free survival with mean follow-up of 9.7 years of the patient. Infection-free survival at 5 years was 94.1%, which was stationary after that. The mean interval to recurrence of infection was 33 months. This chart shows the post-operative complication, which was 9.3%.
1 minute remaining.
With periprosthetic fracture, recurrent dislocation, aseptic loosening, and infection being the complications. The functional recovery was assessed using modified Harris hip score. The pre-op mean of the hip score was 31.2 points, and latest follow-up was 81 points. So in conclusion, two-stage revision remains the gold standard for managing chronic prosthetic joint infection, and our results demonstrate infection control and functional recovery rates which are comparable to the leading Western series. Most patients achieved long-term symptom resolution and a substantial improvement in the modified Harrop-Hip score, translating into meaningful gains in their quality of life. The analysis of National Registry data of England and Wales revealed that the unplanned re-revision risk is significantly lower in the early post-operative period following two-stage revision. The mortality was similar, but two-stage offers more stability. Thank you.
Thank you very much. So for our final paper, I would like to invite Dr. Imran Bukhari, and he'll be talking about registries in clinical practice, a powerful tool for research and publications.
Bismillahirrahmanirrahim. So I'll be talking about the registries in clinical practice. So NGR has published the benefits of the registry for patients. So in a nutshell, they are a powerful surveillance system with timely feedback to surgeons in industry, sentinel for complications with a reduction in patient morbidity. They monitor the new surgical techniques and provide feedback on poor implant design. So 4 essential components of a successful registry: organizational control and funding, participation, data management, and mechanism for timely feedback. So most registries are run by national associations, and needless to say, the funding is critical. So the German National Registry, which was initially financed by industry and sponsors, eventually had to be closed down because of lack of funds. So participation has generally been voluntary. However, the expert consensus recommends that 85% of people should be contributing to the registry, otherwise there will be data skewed by unreported complications and revisions. So utility of registry data depends on completeness and accuracy. So there may be an error rate of about 1% according to laterality and timing. So there needs to be mechanism in place for proper validation. So the economic burden of revision surgery in places where the registries are in place is less as compared to the places where the registries are not present. So in 2010, an ethical study was published. So in the US, the 16.9% revision rate, while 6.4% in Sweden. And each percentage point reduction revision decreases the cost from $40 to $100 million. So the types of data which need to be documented in the registry. So the level 1 data, when you document the patient, surgeon, hospital identifiers, procedural and demographic information. Level 2 is when you document patient factors, comorbidities in ASA class, surgical factors in perioperative care data, complications and adverse events. Level 3 is when you document patient reported outcome measures, disease specific measures. And level 4 is when you include radiographic imaging. So randomized controlled trials are a gold standard, but they entail high cost. So the spine patient outcome research trial and bracing for adolescent orthopaedic scoliosis trial had a budget of 30 million, 7 million, which is a huge amount. So observational research databases have a huge role to play in orthopedics because many ethical topics cannot be accounted for. So that's why registry-based studies are recommended. So Boyer et al. Compared registry-based publications versus RCTs and meta-analysis, and they found registry-based studies had the highest impact between the 3 of them. And this is because of their large cohort size. And so the data is generalizable and can be applied to the real-world population. So registries have raised red flags when potentially harmful trends were recognized. So NGR inception was driven by 3M Capital hip implant failure report as well as the ASR. But remember, registry-based studies evaluate association and not causation. So this is just a brief timeline. So it all started off in 1975 in Sweden, and there are a lot of organizational control which is needed. So the Acta Orthopaedica published an article on the rise of registry-based research, and they found around 4,000 articles have been published to date. This was published 2 years ago. And most of them were in Acta Orthopaedica. And interesting to see is that the growth rate in registry-based studies was 28%.
1 minute remaining.
Versus 10% in the actual orthoplasty registry. So the current state of Asian Joint Registry, Pakistan National Joint Registry is now is part of it. So the E4 Open Review has published on the recent trends in orthoplasty in Pakistan as well. PNGR is there on internationally. So based on PNGR data, we publish an article on the epidemiology of hip and knee replacement across Pakistan. So International Society of Orthoplasty Registries, they published just recently this year on the items that should consistently be reported in any registry. And this is the list of items which need to be documented. So what is interesting nowadays is when in randomized controlled trials, I mean, you randomize individuals to individuals, but now you can do the randomized control within the registry, and this is a new thing. And so the Crystal trial in Australia is being done like this. Yeah, thank you.
Thank you very much. I'm very thankful for all the speakers for sticking up with time. And just a comment that with Pakistan NJR in its 12th year, I think it's time we can have some meaningful researches, data coming out of the NJR. And also one of the common theme of all the speakers was that we have to have more multi-center randomized controlled trials. So I think it's high time for our national organization to have a research unit in which we can have multiple studies going on at the same time in different hospitals to have better outcomes, data and outcomes. And I would like to request Professor Isran Ahmed for his concluding remarks for the session.
Thanks for all the presenters for presenting their nice scientific work. This included conservative treatment of arthritis to joint replacement and up to registries. Due to time constraint, we cannot take questions. So Alhamdulillah, we have come to the end of the first session. This is always challenging to start a conference and the first session in time. Thank you very much, and we conclude this session, and we will hand over the stage to the next chair and moderators. Thank you very much.
Thank you very much to the chair. This is a fantastic start. I think in the history, we are now 8:31, so we need to catch up with that 1 minute that we've missed. Some housekeeping rules, if I can. There are no fire drills. You should be aware of the fire exits and toilets by now. We need to specially mention that there is a Palestinian stall for donation. We would love for all of you to donate generously. I know my child is doing that. We're also here to say that Pakistan Arthroplasty Society intends to match all the contributions that come through. So a round of applause for them. Just to mention, you may already be aware, but there are two conferences happening during this weekend. The second conference on Sunday will have a separate registration, and this is the first orthopedic oncology conference. And with that, I would request that we start with the national anthem, and I would request the participants if they could stand out of respect for it.
All
much. Let's officially start the session. I'd like to request Professor Syed Shahid Noor Sahab to come and give us the welcome note. Thank you.
Bismillahirrahmanirrahim. Ladies and gentlemen, welcome to the second International Pak Arthroplasty Conference. I'm extremely grateful to my friends who have come all across the world and have faced difficulties with flights and other things, but you are here. So to each of you from different countries, whether it be UK, Australia, Philippines, Iran, Turkey, all around, Singapore, thank you very much. So we have invited 25 top international faculty for this conference. We have 50 national faculties for this conference. Today's session is more on the hip arthroplasty. We will have a primary hip arthroplasty session. We'll have a revision hip arthroplasty session. But the cherry on the cake is the PGI symposium, where we will have 2 lectures from Professor Jawad Pravezi, and we will have some case discussion. I hope you will enjoy this academic endeavor. It's a great thing that 8:30 in the morning, we've started on time, and I would request all presenters to stick to the time, and thank you very much.
Thank you very much, Professor Shahid Noor. We'd like another welcome note from Professor Dr. General Sohail Hafiz Sahab. Thank you.
Bismillah ar-Rahman ar-Rahim. As chairman of the organizing committee, first of all, I would like to welcome everybody to the second International Arthroplasty Conference here in Islamabad. I'm grateful to all the members, delegates who have traveled far and different places from Pakistan and from abroad. Looking back, I vividly remember that in February 2012, 12 of us sat in one of the hotels in Karachi and said we should have a society or a group where we can learn from each other. And we formed the Pakistan Arthroplasty Forum, which matured into the society in March 2013. And we set certain goals for us. One of the goals was to hold workshops for the younger lot to transfer the skills. And I'm proud to say that we have conducted more than 32 knee and 28 hip arthroplasty workshops in the last 12 years, not only on primary hip, primary knees, revision hips, revision knees, in shoulder, all over the country, not in big cities, but also in smaller cities like Multan, Sahiwal, Quetta as well. We also started our national fellowship program where young arthroplasty surgeons desirous of taking up this challenging field are trained for 1 year under the supervision of high-volume arthroplasty surgeons. And I'm proud to say that we have trained so far 60 arthroplasty surgeons. Some of them are now consultant in their own rights and are the member of the faculty. Some of them we have been able to send abroad on international fellowship program, and we would like to continue this exercise. We were also instrumental in running the arthroplasty session in all the orthocons, and these were one of the most successful sessions which came. Needless to say, we also promised to have a national joint registry, and our society was the first one to start the Pakistan National Joint Registry. And today, I'm proud to say that we are publishing the 11th annual report of our registry. Holding an international arthroplasty conference was a dream. In fact, we had to kick a few people And to encourage them, we thought that we would not be able to do it. But the first conference that we held in Karachi 2 years was a resounding success. And this second fellowship, conference actually speaks volume that we thought that we'll register only 400 participants. I'm proud to say over 700 participants have registered so far. And being the organizer, it's a challenge for me to arrange their food, their meals, and everything. What are we looking forward to? The society is looking forward to holding these conferences biennially, continue their programs. I'm proud to say, as the Dean of Faculty of Orthopedics at CPSP, that we are going to start FCPS Arthroplasty from next January, inshallah. It would be a 2 years program, and it would be culminate after an examination. So this is one of our success, that through the platform of this society, we have been able to push the college to have a separate fellowship program. Above all, this conference is meant to get our friends together, to develop or rekindle the bond of friendship, to meet each other, and develop an international platform on which we can share our thoughts, our ideas, and our friendship. In the end, I would again like to thank you all. If there is any problem, I was saying last night, if you like something, please give credit to our patron, Professor Shahid Noor. And if you find anything challenging, you have a difficulty, you can blame me for it, or you just say something in my ear and we'll sort it out. I hope and pray you have a wonderful stay with us, a comfortable stay, and we look forward to have 3 days of intellectual pursuits over here. Thank you very much.
Thank you very much. Let's formally start the session. I'd like to invite the chair, Professor Muhammad Umar, please, if he's around. The co-chair, Professor Sohail Amin, sir. And the moderator, Dr. Imran Kaisarani, please. Over to you all.
Bismillahirrahmanirrahim. Thank you very much. We have now officially kick-started the session. We will start with the first talk of this session on primary total hip arthroplasty. A newer approach that is doing the hip through the direct anterior approach has been around for quite some time now. But the gadgets and things that are linked to it make it difficult for the regular surgeons to perform it. Let's learn from Professor Antonio how to do it on a regular table and how to avoid complications.
Thank you very much, Mr. Chairman. First, I'd like to thank my good friends, Professor Shahid and Professor Amin and the rest of our arthroplasty colleagues from Pakistan for the kind invitation and for the success of this meeting as well. So I bring you warm greetings from Cebu in the Philippines. And as you very well know, the direct anterior approach is not a new approach, but then its application in total hip replacement has gained leverage and popularity over the last few years. These two particular papers looked at the direct anterior approach using a regular OR table and not a traction table, and it showed that there's no significant difference in terms of complications whether you're using a traction table or a regular OR table. So I'm going to be showing to you how to avoid complications with the use of this particular approach in doing a total hip replacement using just a regular operating room table. I have no conflicts in relation to this presentation. Here's one of my patients. He's a 58-year-old physician complaining of post-traumatic arthritis over the right hip, for which we did a direct anterior approach, total hip replacement using a short stem, using a regular table. And here you see him just on the afternoon after surgery, now able to manage stairs. And as was mentioned earlier in the free paper session, the advantage really of a direct anterior approach is that with lesser soft tissue injury, we now are able to allow our patients earlier ambulation and faster recovery. Here's another patient of mine. He's a 72-year-old Caucasian, again with degenerative arthritis over the left hip, undergoing a total hip replacement using direct anterior approach on a regular operating room table. Here's a video of him at 2 weeks after surgery at his home, 6 weeks after surgery at the office, and also 6 months after surgery with barely a limp noticeable after having gone the successful procedures. Now, while we know that the traction table is the most popular device for the use of direct anterior approach, in the absence of this resource, you can actually use a regular radiolucent operating room table, but just to make sure that you position the patient further distal in the table so that you have access for your C-arm to be able to visualize the hip. Patient positioning is probably one of the most crucial factors when you are using a regular table for doing this particular approach. The use of special Hohmann retractors that allow you to visualize the acetabulum and mobilize the proximal femur as well are mandatory. The use of a bone hook for you to be able to mobilize the proximal femur, using offset handles for both your reamers and the broaches for your femoral preparation. So all these are available basically with most implant providers for the direct anterior approach implants. But like I mentioned earlier, positioning is very important. We position the patient on a regular table, but we have to make sure that the hip is actually positioned where the break of the OR table is. Because the moment you expose your proximal femur, you need to be able to bring the whole leg down to be able to mobilize the proximal femur. Putting a sandbag underneath the posterior superior iliac spine will also help elevate the whole pelvis anteriorly so you get better mobilization of this area. And as you see on the diagram on your left, when you expose the proximal femur, you actually bring the extremity which is being operated on under the contralateral extremity in a figure of 4 position, bring it into adduction so that you get better visualization with the proximal femur. Avoiding complications starts here. Now the approach is pretty standard whether you're doing with a traction table or regular OR table. As was mentioned earlier, it's an intermuscular plane. And this intermuscular plane between your sartorius and your tensor fascia lata allows you good access to both the acetabulum and the proximal femur. Hohmann retractors then are applied over the anterior wall of the acetabulum, the superior neck and inferior neck for you to do your capsulotomy or capsulectomy as you see here. And then eventually, in preparing the acetabulum, you apply your Hohmann retractors anterior, inferior, and posterior inferior in the traditional way. It's just that your visualization of the acetabulum is different because you're approaching it from the front. The advantage of doing a direct anterior approach is that you're able now to bring in the C-arm to check on your position even while you're doing your reaming before applying the acetabular component. And if you're able now to confirm this, then you're able to confirm that your position, the position of your acetabulum is ideal, falls within the acceptable range, lessens the likelihood of complications. So again, a big advantage of doing a direct anterior approach is the visualization using a C-arm, and you get the true AP view of your acetabulum. Then eventually we start preparing the femur. This is where the challenges start, because if you don't do the releases properly, you will encounter difficulties and complications in being able to see your proximal femur, leading to a lot of complications. So first, the pubofemoral ligament has to be released at the 6 o'clock position, after which you've done your capsular releases. You now bring the leg in the figure of 4 position, posterior to the contralateral leg, releasing the capsule at the superior or 12 o'clock position as well to mobilize the proximal femur, and doing what we call an internal release of the gluteus medius insertion. There are normally tendinous portions that are very taut when you mobilize the femur, and all you need is to release this tendinous portion. You do not need to release the gluteus medius insertion that extends down the greater trochanter. After this, once mobilized, now you're able to do your femoral trial after your broaching. And once again, the advantage of this is that you are now able to visualize on your C-arm the position of your femoral component. After you've done your broaching, put in your final implant and visualize the position of your femoral component. Then do your reduction and closure. And this is how it appears with the C-arm. So again, even with just the broach in place or the final implant in place, the advantage is you're able to visualize it with the use of the C-arm. And this is when the advantages, these are basically some of the advantages of using a direct anterior approach even on a regular operating room table. But then this particular approach is not devoid of its own set of complications. I'm going to show you my own experience of complications that have happened because we want to be able to learn from this and avoid these complications. Here's a patient of mine. She has osteoarthritis on the right hip and a femoral neck fracture on the contralateral hip. for which we did a sequential bilateral direct anterior approach total hip replacement. And as you see here, we know she's elderly, she's 76 years old, she has osteoporosis, so even with placement of our retractors, we fractured the greater trochanter on the left side, fractured the proximal femur, and while the acetabulum on the contralateral side looked ideal, the following day after surgery, she dislocated her right hip. And this is when we discovered that our acetabular component was too anteverted, it was malpositioned, despite us being able to visualize it intra-op that we thought it was in the right position. So again, we had to revise her right acetabulum, but we also discovered that she had a periprosthetic fracture in the left hip. And we were dealing with an elderly patient with osteoporosis. And so because of the osteoporosis, as we see here, we had other complications like avulsion of the greater trochanter on the contralateral side after we had repositioned our acetabulum, and a periprosthetic fracture on the left hip. We treated her conservatively, giving her denosumab and teriparatide, and here she is at about 2 months after surgery, being able to mobilize now. 4 months after surgery, she's able to successfully ambulate without pain. But then again, we don't expect to be as successful or as lucky with other patients as well. Now, there are cases, particularly in osteoporotic patients, where you can have perforation of the lateral cortex of the femur, particularly when you start your broaching. And what's most important here, what's most important here is that you have good visualization with the proximal femur for you to be able to apply your broach and your implants properly. Time's up? Okay. I'll stop there.
Yes. Thank you very much. An excellent talk on how to do a total hip arthroplasty through anterior approach on a standard table. I remember the words of my teacher. They used to say that the two most common complications leading to revisions are infection and instability. The placement of components is very important to avoid instability, especially the placement of cup. I welcome Professor Rame Sorel on the stage to have a talk on optimizing cup placement in primary total hip.
Thank you very much, Shahid, Amin, Sohail. Team PAS, thank you for the invitation. I bring greetings from Sydney in Australia. And I'm talking today about optimizing cup placement. And Tony gave us a good example of you think you're putting in the right place, but what is the right place? This is what this talk is about. But we all like seeing something like this. This lady came in this year. 27 years ago, I did both sequential right and left hip replacements, 1998. 75 years old now, still going well. She's 140 kilos. 28 millimeter heads, first generation polyethylene. They can still work, you just got to get it right. Optimized cup placement equals long-term stability and survivorship. We know from the joint registry that instability is in the top 4 reasons for revision for primary THA, and for fractured neck of femur THA, it's the #1 reason for revision. And you've got to take gender and age into account. Certainly female gender, higher risk of instability. This is a disaster, that's what I call it, and if you make wrong decisions, it becomes a catastrophe. You do not want to see that. How do you prevent it? Just do the cup in the right position, that's a good starting point. We can't go past Leeuwenhoek, we've got to mention it, the safe zone. 40-20 is what we aimed for at least 2 decades. But Pagnano's group in the Mayo Clinic showed us that the safe zone isn't that safe. The majority of dislocations in their series, 58%, were in the safe zone. So there you have it. Dan Berry reported, now this is historical really, but it showed a 1% risk at 1 month of dislocation and then an extra 1% every 5 years. So by 25 years, you've got a 7% risk of instability. There are patient factors, we know that. We can't control some of them, but we can control surgical factors, in particular component malposition and impingement. We used the transverse acetabular ligament for a long time. That was our guiding light. Basically parallel and just 5 millimeters in will control version and inclination. That's what I used for the first case that I showed, and I used that for quite a number of years. But we've moved on from that. And in fact, some of the publications now show that TAL is no longer an accurate intraoperative guide for cup positioning in the presence of pelvic tilting. We're talking about spine. Spine pathology is an issue, it impacts. There's a patient who was stable for 17 years, but after 3 spinal procedures, she popped out after 5 weeks and presented to me. So the spine plays a big role. What is that role? If you look here at this publication, up the top, the blue line is isolated total hip replacement. then each one is with the number of spinal fusions. So the more spinal fusion, the more likely you'll have instability, poor survivorship. This one by Warwick Bruce looked at patients with prior lumbar spine fusion, significantly increased risk of dislocation and of revision. Surgeons should pay particular attention to these patients and consider using some optimal way of positioning the acetabular component. Larry Dorr looked at this, recently discovered spinopelvic motion is a coordinated biomechanical relationship among acetabular anteversion, pelvic tilt, and lumbar lordosis. So ideally adapt your spinopelvic interactions into your positioning. We know the spine goes and impacts on the position of the acetabular component. The pelvis tilts forward as you stand. There's a lumbar lordosis. And then as you sit down, not only does the hip flex, but the lumbar lordosis irons out, the pelvis tilts backwards. If this doesn't happen, you end up with either a stuck standing or a stuck sitting position, and that can lead to impingement. Impingement is what causes instability. And if you fail to take that into consideration in someone with spine pathology or a lumbar spine fusion, then you may end up with instability. The stuck standing, stuck sitting position are here, but essentially what they'll do is cause impingement either anteriorly or posteriorly, leading to a dislocation. Ranawat looked at the loss of anterior pelvic tilting, and for every 5-degree loss of motion, you lose 2.5 to 5 degrees of anteversion. You've got to take that into consideration. The preoperative assessment of biomechanical relationship between the spine and the hip has become a more important step in the evaluation. This is probably the best paper I've read, and I'd recommend it to you, by Jonathan Vigacek in 2023. He looked at the at-risk spinopelvic parameters: pelvic tilt less than minus 15 degrees, lumbar flexion less than 20 degrees, and mismatch of greater than 20 degrees are red flags. And if you get a red flag, consider a dual mobility as an option instead of fixed bearing. These are how these are measured. I don't have time to go into it, but essentially these are the 4 red flags that could potentially come up with spine pathology. 11% of his control patients, over 9,000 patients, had a spinopelvic risk factor, but of the dislocating cohort, 2/3 of them had one or more spinopelvic risk factors of those 4 that were mentioned. Now, we all recall historical templating. Some of us still do that. I've moved on from that quite a few years ago. But it worked, and that first patient I showed it for a reason, to say you can still get good results with basic templating, but it's 2-dimensional. We now have the ability to do 3-dimensional templating and take that into account. We looked at anteversion inclination. It was kind of a guesstimate, and here experience counts, and with less experience you're less likely to hit the right mark, therefore you're not optimizing position. This is how I currently do my templating. It's 3-dimensional, based on CT. Every patient gets this preoperatively. I assess it, I approve it. The engineers give me an optimized simulation of the tracking of the center of the rotation of the femoral head in the acetabulum. I can look at it in 3 dimensions. I can see where that cup needs to go. There's the spinal parameters up the top there. I can change version. I can change inclination to optimize position. If I have a red flag, that's the sort of patient that I will use a dual mobility in. If there's no red flags, I'll use a fixed bearing. My use of dual mobility at the moment is about 5%. 3-dimensional templating means you can see where cup contacts bone, and optimal position and sizing, optimal version, optimal inclination, taking into account spinopelvic parameters. The heat map tells you how much contact there is with the bone, both for the femoral and acetabular components. I don't have time to go too far into that, but delivery system is important, whether you use robotics, laser, PSI. I use a PSI system. That means the plan that you've actually harnessed is then delivered onto the patient. If you have a plan like this, there are no spinopelvic risk factors. So I go with the fixed bearing. If I have a plan like this, you can see there's about 3 or 4 spinopelvic red flags. This patient gets a dual mobility. That's how I make the decision. So in summary, modern THA has become very sophisticated. Optimize cup position to reduce or eliminate dislocation risk. The modern system for cup, well, you get the gist. Thank you very much.
Thank you very much, sir. Now we would request Mr. Duncan Whitwell to come onto the stage and tell us about doing tips and tricks of a total hip in an ankylosed hip.
It's a great pleasure to be here again, back in Pakistan, in a place where we have sort of similar opinions on orthopaedics as we do on which side of the road we drive on. Historically, we've often done hip fusions, and these are now actually in your country are being done less and less. It's for infection or bad trauma. And because now we've got a very low threshold for actually doing arthroplasty. And this is a patient who was 16, my youngest hip replacement. Leukemia, was on steroids, had AVN, and actually I felt the best for this patient was to have a hip replacement and with a ceramic-on-ceramic bearing. But these ultimately may need to be converted. You do actually have overall excellent outcomes with hip replacement conversion, but you've got to be very careful with your preoperative assessment, looking at where the bone is and where the bone isn't, and also the soft tissues, the abductor strength, looking at maybe assessing them with an MRI scan. Specialized approaches, maybe even anterior, and good soft tissue releases to avoid contractures afterwards. So here you have a refused on the right-hand side, which has been converted with a trochanteric slide. But on the right-hand side, you've actually got an ankylosed hip, where there is hardly any movement, but it's not an actual fusion. And these are challenging as well. Often the cause of these are due to chronic inflammation, ankylosing spondylitis, with the fact that there's adjacent spinal issues as well, rheumatoid arthritis, even severe degenerative changes as well. And then you also have them secondary to trauma, infection, vascular necrosis, and severe DDH. You've got to be thinking about sort of the scars, the previous surgeries that have happened, the disordered anatomy, where your joint center is going to be, how you're going to get there. So maybe you need to have image intensification, the altered biomechanics, and we're going to hear in a number of times the spinopelvic mobility and how important it is to assess that beforehand. Occasionally, you might even have such difficulty that you have implant malposition, even to the extent of these cases. And then you've also got to think about metalwork removal as well. This is one of the more complex sort of cases, actually DDH, a very stiff patient. I could have elected to do a shortening osteotomy. We didn't think he was that short, so actually less than 4 centimeters, so actually we went for short stems. The right went very well, but you can see on the left-hand side it was a bit difficult. We actually had a periprosthetic fracture and it needed wiring. So again, technical difficulties associated with these challenging cases. This is the fortunate patient I met on a visit to Malta in the Mediterranean. Had been in bed for 6 months with a fixed adduction deformity of both her hips due to JRA. And this was actually her hip on the operating table just before we were due to operate. Again, we did sort of short stem implants on her, ceramic on ceramic bearings, and that was rewarding that it was the first steps in almost a year that she took with a Zimmer frame afterwards. In trauma, we have cases like this, very stiff hips that we've got to get access to, with metalwork also pleasant as well. And you sometimes do have significant bone loss that you sometimes can get away with just a hemispherical cup, but sometimes you do need to actually put augments or even extra bone graft in to reconstruct the bone loss. Again, these patients often tend to be young, so you're talking about high performance bearings, ceramic on highly cross-linked polyethylenes. This is an interesting case who was a bilateral amputee after trauma, and he had a very stiff right hip that was in a fixed flexion deformity that couldn't allow him to use a prosthesis like he could on the left to actually ambulate, and he was stuck in a wheelchair. Again, really the only option here to get this hip going was to actually give him a hip replacement, and that was allowed him to, after 3 months, get both his prosthesis on and to ambulate with 2 above-knee prosthetics. So sometimes that's the only option that you can do to get these cases. Looking at the literature, we know that actually these cases can give some reasonably good outcome, but they're complicated. We really do think they're complex surgeries with a higher complication risk. And about 20% complications were reported in this study, which are similar to a number of other studies out there in the literature. Infection, fracture, early failure, and things like hypertrophic ossification are quite common. So here's sort of the list of the complications you can get in these cases. all the way down. And so there's ways you can sort of assess them both intraoperatively and postoperatively. Preoperatively, thorough clinical and radiographic planning, templating, adductor assessment with MRI scans. That spinopelvic mobility assessment, I think, is important. And if you're unsure, the use of dual mobility may keep you out of trouble. Preoperative anesthetic assessment's vital. Some of these patients, like the ankylosing spondylitis, may have stiff necks, etc., that need careful or anesthetic review. Consider stopping immunosuppressive biological agents if they're rheumatoid, and prepare for possible soft tissue contracture release. Patients need to be warned they might have more than one incision with their surgery. Intraoperatively, careful positioning, gentle soft tissue handling to try and reduce heterotopic ossification. An in situ femoral neck cut is probably important. You won't be able to dislocate these normally, so you have to do a cut, mobilize the femur, and get the femoral head out with a corkscrew. Restore correct hip center. Occasionally you need to get an image intensifier to actually get your help with this. And sometimes, again, you have to reduce your acetabular anteversion to maybe compensate for that spinopelvic mechanism. And if you're concerned, dual mobility bearings probably get you out of trouble with that regard. Postoperatively, often these patients need a higher risk of heterotopic ossification. Consider post-op indomethacin, adequate DVT prophylaxis, antibiotic prophylaxis as well. Early mobilization with physio is important, and monitoring for infection, loosening, and dislocation. So in summary, it is by far the preferred treatment to give them a hip replacement rather than allow them to have a stiff hip with the adjacent issues to the joints associated. Most patients see significant improvement, but there are complications and potential need for revision should be discussed with patients so they have proper informed consent. And then you do careful pre, intra, and post-operative planning. And you get patients like this. Thank you very much.
Thank you very much, sir. We have dedicated time for question and answers at the end of the session, but we can always take one or two questions in between sessions as well. If there are questions, we can take them in between the sessions as well. For the next talk, I will invite Professor Naeem Ahmed to talk about THA in a dysplastic hip, CRO 2 and 3.
Bismillahirrahmanirrahim. The topic is long, but the time is very short. So I try to cover as much as possible. So first of all, I'll start with the CRO classification. As you all know, the CRO classification is divided into 4, type 1, 2, 3, 4. And the type 1 is when there is less than 50% of the subluxation. Type 2, when there is subluxation between 50 to 75%. Between 75 to 100% is type 3, and type 4 is more than 100% subluxation. And as you all know, the reconstruction or THA in a patient who has osteoarthritis and who has DHA, it's a very important to understand the basic anatomy. The basic anatomy in patients who have dysplastic hip is everything is different. There are changes in the acetabulum, there are changes in the femur, and the soft tissues are there very short. So it is mandatory to understand the nature and extent of the preoperative deformity and the structural abnormalities, and to know the complexity of the THA in patients who have already very small and young patients. The soft tissues, they are very thick, the capsule is thick, they are short. Muscles like iliopsoas, rectus, adductors, hamstrings, and there is, if you talk about the abductor, they are horizontally arranged, and there are vessel problem as well. Now, if we talk about the acetabulum is shallow. It is oval from side to side, and it's very narrow. There is increased anteversion, and the center of rotation is more lateralized. The femur is again very, very dysplastic, small, narrow canal, loss of metaphyseal flare, the narrow mediolateral canal. There is increased anteversion, and because of all these, they are very difficult in putting in the implant in a normal way. So for radiological assessment, you need to have two angles to know, that is central edge angle and the Tonys angle. And coming to the assessment, the treatment depends upon the severity of the disease, extent of the osteoarthritic changes, and the age and the functional goals of the patient, and above all, the availability of the bone stock which is there in the dysplastic hip. These patients, they present early, and they present with a pain and limping gait and lurch. And some of the patients, they present late because of the low back pain, because of compensatory lumbar lordosis. In the CRO 2 and 3, they are the patients who present even earlier because of early changes in the hips, because of degenerative changes. And before going for surgery, we must consult the patient regarding the residual limb-leg discrepancy, limping, and some of the other complications like injury to the sciatic nerve and the vessels. Preoperative planning is again important to know about the proper functions of the patient and to know about the functional anatomy of the patient. For this, we need to have X-rays and CT scan to have the better assessment of the bony architecture of the acetabulum and the femur. The templating again is important, and we must be prepared for the size of the components, which need to be very small. The size of the cup should be 38 to 40. And again, the different types of straight sort of implants in the femoral component should be there, and we must know where we need bone grafting. The idea of all this is to have a center of rotation as close to normal as possible. And the indications, you all know that all these patients who they present late, maybe in their second or third decade of life with pain and disability because of the pain. So in CRO 2, the approach may be anterolateral, posterolateral, depending upon the surgeon choice. And in CRO 3, since the hip is high up, we need to bring the acetabulum and we need to bring the femur down. For this, we may have trochanteric osteotomy or subtrochanteric approach. The soft tissue must be released to mobilize the femur down, and again, the excessive soft tissue release should be there, but over lengthening, maybe more than 4 centimeters, should be avoided to cause injury to the sciatic nerve. Acetabular reconstruction, the best bone stock available again at the site of the true acetabulum. This is important, and these are the options in patients who have dysplastic hip. If you imagine that the hip is very high up, we need to bring the femur down at the level of the true acetabulum. If the bone stock is not there, we can have a high hip center, which is shown here A. And if you want to bring the acetabulum, femur close to the true acetabulum, then we need to cover it up maybe with a structural bone graft, or we need to medialize the cup by doing a medial approach. So if the head remains uncovered or your cup remains uncovered more than 30%, only then you need to do a reconstructive procedure on the acetabular site. So this is how we can reconstruct the acetabular site. We deepen the head. The remaining uncovered portion of the cup should be reconstructed with a portion of the head and applied with the 2 screws. Another way of giving space to the acetabular cup is to medialize the cup by doing more reaming on the medial side.
Remaining.
You medialize the cup by control reaming and perforation of the medial wall so that the cup can be fit in very well in the acetabulum. So this is how you ream the medial wall and place the cup medially. Now coming to the femur. The femur is again very deformed, and if the anteversion is more than 40 degrees, then you need to have a derotation osteotomy of the femur as well. For high up, to bring the femur down, we need to have shortening osteotomies, and there are 2 types of shortening osteotomy. Number 1 is a proximal resection osteotomy, in which you remove the metaphyseal area, and number 2 is the subtrochanteric osteotomy, in which you remove the portion of the femur to bring the femur down against the acetabulum so that there would be no excessive traction on the sciatic nerve. So this is how we do it. Sometimes the greater troch is again is at the higher level, in which the tip is high up, you need to bring the tip of the greater dog below the center of the acetabulum. For the stem, if femoral stem normally is used a Wagner straight stem which fits in the diaphyseal area of the femur, and sometimes you need to have a modulate stem, in which a case where you have more anteversion of the femur. To correct the anteversion, you need a modulate stop type of the implant, so that you correct the anteversion at the same time. So in summary, for the dysplastic hip, one must be prepared for all the implants which should be there, like all the implants in all ranges in terms of the sizes, and you must know how to bring the femur down, how to release the soft tissues, and how to restore the normal center rotation of the hip joint. Thank you.
Thank you very much. Now let's build on this information of how to do doing a hip on a CRO 2 and 3, how to do a CRO 4 through direct anterior approach without subtrochanteric osteotomy. I would welcome Professor Jawad Murtazavi.
Assalamu alaikum, good morning. It is a pleasure for me to be here, and I would thank you for the kind invitation to be part of this program. I have nothing to disclose, and as you know, do we need to do THA in patient with chorotype 4 DDH? I think we need to do total arthropathy in these patients that nowadays, because it affects the social life of those young patients. But total arthroplasty in DDH type 4 patients had triple complexity on acetabular side, the femoral side, and soft tissue. And it was called the most complex primary THA. On acetabular side, we have severe deficiency, we have distorted anatomy. On femoral side, we had hypoplasia, excessive anteversion, stenosis, and deformity, especially they have previous osteotomy. And in soft tissue, the soft tissue challenges affect ligaments, nerves, and muscles. The solution, the traditional solution for this deformity was in acetabular side, we put the stem in through acetabulum and use bone graft for the deficiency. In femoral side, we used to use small conical stems to address hypoplasia and anteversion, and for soft tissue problem, we use femoral shortening, different femoral shortening to address the soft tissue contracture and extensive release. Our data on these approach on 40 hips shows 6 dislocations, 7 revisions, 2 transient nerve palsy, 8 patients remained with limping after surgery, 2 purposive fracture, 1 PJI, and 1 cup loosening. So we decided to change our approach for these patients. Our change in approach based on 4 facts. Fact number 1, proper compositioning is not within the true acetabulum in patient with type 4 DDH. True center of rotation located higher. You can put cup higher in this patient without affecting the outcome, and you have less complication with to put cup higher, because you can put larger cup and you get less lengthening. Several studies showed that it's a valid technique to put cup higher. You have more optimal bone coverage and more secure cup fixation over there, and you can restore the femoral offset and as abductor level arm putting cup higher. And finally, in this WEMA question, we showed in a systematic review that there is no difference in HHS, abductor level arm, limping, dislocation rate, nerve injury, and acetabular cup revision when you put cup in true acetabulum or put it higher. So we decided to put cup in optimal position, which has more bone coverage, more secure fixation, and allow us to put a larger cup. The second fact is the fact the abductor mechanism attached to the facet, not to the tip of greater trochanteric. They attach more distally in DDH type 4 patients. And several anatomic studies show that the attachment of abductor actually separate from greater thoracic the small bursa. And the fact number 3 is that the tip of greater trochanter to lesser trochanter distance is higher in DDH patient, as you can see here. It is higher. So the second modification is that we could preserve abductor while we do supratrochanteric shortening and greater trochanteric trimming. And factor number 4 is the fact that DDH approach in type 4 DDH give you superior acetabular exposure, optimal cup orientation, control soft tissue release. You can check the limb length during the surgery, and you can do the stability checking in functional positions. So this is our approach. We put the cup in higher position, optimal position. We did the trochanteric reaming, and we cut the neck as inferior as possible, and then we put the cup inside. This is a short video show our technique. This is a 34 young old male with 48 millimeter shortening. As you see, this is the direct anterior approach. I extended it proximally to be able to detach tensor fascia lata from the iliac wing to get approach. We do complete capsulectomy to direct anterior approach. We then cut the head and neck. As you see, we measure the tip of greater trochanter to lesser trochanter, and in this patient it's 45 millimeter. We release the femoral shaft completely, and then we remove the capsule to expose the acetabulum. As you see, this is the true acetabulum, and this is the ridge between the true and false acetabulum. I remove the ridge, and I start reaming just at the ridge, not below the ridge. So I put the first ream forward and the rest of reaming backward to impact the bone. I use usually the advanced metal technology cup, like tantalum cup. And then I go to the femur, shortening femur up to lesser trochanter, and remove the tip of greater trochanter while keep the attachment of abductor muscles. I put the stem, I check the stability, and I check the leg length at the same time. The closure is easy, like. So this is the post-op X-ray. This is 1.5 month post-op, and the patient walk without limping. This is another patient, 31-year-old, 45 millimeter LLD. This is the 1.5 year follow-up X-ray, and you see the function of the patient. This is the range of motion of the hip, flexion, internal rotation, external rotation, and you see the abduction. In most of these patients, the abductor can get good function, and the sitting of the patient, and this is the walking of patient without any significant limping. We did 78 hips in 57 patients with average follow-up of 32 months. Clinical LD decreased from 4 centimeters to 1 centimeter, and our average lengthening is about 3.5 centimeters. We had complications in these patients. 16 patients still have limping, 4 transients nerve palsy, 6 dislocation, 1 PGI, 1 cup loosening, but no non-union or revision for femoral stone failure. THA without shortening, also reported in literature for different authors, but not through direct anterior approach. And this study actually shows that osteotomy versus non-osteotomy, shortening because no shortening cohort, there are more complications in shortening cohort. So in conclusion,
1 minute
direct
remaining.
anterior approach is optimal, enables optimal cup positioning without shortening, facilitates dynamic stability LLD assessment during surgery. We use to avoid routine shortening because there are non-union risk and prolonged rehabilitation, but there is two important technical tips. You need to put the cup in optimal position higher than usual, and you need to use conical stem with supratrochanteric shortening or greater trochanteric trimming. Thank you very much for your attention.
Excellent talk. Now let's move on to the next talk, which is doing a total hip and a dysplastic hip CRO 4 with subtrochanteric shortening osteotomy by Professor Ismail Ramzi.
Thank you very much. Thank you very much for the organizing committee and Dr. Noor for invitation here. It's a great honor to be here. I'm going to talk about the femoral osteotomy techniques in THA in CRO type 4. Mostly for high dislocation, there is no possibility to bring the hip center of the rotation to its original anatomical location without shortening because of the risk of neurovascular injuries. Femoral shortening osteotomy became a standard within the years, but level and type of the femoral osteotomy shortening amount, type of implants, and type of stabilization varied not only among the series, but also within the series. Therapeutic planning is very important. This is the bilateral cases. Planning, we did one side first, 4 months later, you can see here. We can do osteotomies, proximal osteotomies and subtrochanteric osteotomies. We can do transverse, oblique, or chevron type of osteotomies or step-cut osteotomies. Transverse is technically easier, but round stems provide less rotational stability. Rectangular stems are more appropriate. For rotational stability, we can choose cementing, supplemental plating, placement of endostal bone packs. Also, we can do oblique or chevron type of osteotomies. A biomechanical comparison of transverse, oblique, and step-cut osteotomies has shown the step-cut osteotomy significantly increases the torsional stiffness. Because of that, we prefer to use the step-cut osteotomies in our cases. Although step-cut osteotomy was evaluated as a time-consuming and laborious by some authors, the proximal cut of the step-cut femoral osteotomy was performed after femoral broaching, unless any canal deformity prevented straight axial reaming. For correcting the rotational problems, femoral osteotomies were performed in 2 different neck rotations. In the first step, the neck was placed in the desired anteversion relative to the floor, usually by internal rotating the intact femur. Following implantation of the acetabular component, trial components were placed in the proximal femoral fragment, with trial neck and hand joint was reduced. Gentle traction was applied on the leg. The bone overlapping at the osteotomy site was marked for the shortening amount. This is the version differences, and we can do it after canal preparation, and we did osteotomy, and we use cables for fixation. We can use different type of the incision, lateral or posterior type of the incision, and Javad said is the direct anterior type of the incision also. We can prepare the first femoral canal, and after that we can do an osteotomize. Here is some of our cases. We did one side, later left side. This is the late results, 17 years later and 15 years later result. And other cases, very limited range of motion. We did one side first, 5 months later we did another side, and you can see here more than 13 years result bilaterally. For previous valgalization type of subtrochanteric femoral osteotomized cases, femoral step-cut osteotomy and resection was done before canal preparation. In this case, we did step-cut osteotomy and we removed the screw and plate first. After that, we can reach easily to the true acetabulum. We can resect the capsule and we can reach the acetabulum. We can prepare the acetabulum easily. And we implant the acetabular component, acetabular shell, in this position. Here it is for resection of the acetabulum and preparing the acetabulum. We have to prepare the forward of the acetabulum, forward to the ischium, we implant it. Here is this case, very severe, very limited range of motion preoperatively and very severe flexion contracture. We did right side first, 6 months later, we did the other side. And 5 years later, she had some pain on the right side. We revised the right side for cemented femoral component. Here is the 11 years later left side, and after the revision 7 years later, right side. You can see the range of motion is very nice, and abductor muscles is quite nice. Another case is 53 years old, previous osteotomized. We did left side first, right side left, and more than 20 years result you can see here. Another case is previous osteotomized. That's the 14 years later we noticed the right side osteolysis and we revised it. And you can see nearly 30 years later on the left side result. And first 2002 we published in Journal of Arthroplasty its first 28 cases. There was 2 non-union. In 2016 we looked again the same series, but we reached 18 hips. Main revisions were due to the acetabular side liner locking mechanism. And also in 2016 we looked at monoblock stems. We used anatomic image, synergy, and energy echelon type of the monoblock stem, different stems. At 10 years, 85% is success. And cylindrical stem, superior neutral alignment, less complication, and no non-union. Last 10 years, CDH or echelon cylindrical or SLR rectangular stem performed better. Main shortening amount was 3.5 centimeter, 2 to 6 centimeter. Cerclage wire or cable was wrapped around the osteotomy side. Except for 6 cases, the resected bone segments were used as a strut grafts to augment the osteotomy fixation and encourage the osseous healing. PHA with step-cut femoral shortening and the rotational osteotomy is the most stable one and provides significant improvements in functional capacity. Despite the shortening osteotomy, an average lengthening of 2 to 4 centimeters can be achieved. Non-union at osteotomy site could be reduced with stable fixation using the resected segments as a strut graft. Cylindrical, long cone type, or long rectangular femoral components should be preferred for primary stabilization of the osteotomy. Intraoperative neuromonitorization is important. Neuromonitorization useful to detect early neurological deficit and to prevent irreversible neurological damage during complex primary or revision total hip arthroplasty. And last year, in the World Expert Meeting, another question is there a limit to lengthening? As a conclusion, they found that there is no only limited and conflicting evidence. There is a risk for neurological complications. In the absence of any definitive limit, surgeons may decide to lengthen the extremity more than 4 centimeters. With careful intraoperative monitoring and maintaining the knee in a flex position intraoperatively and postoperatively, restoration of length may be considered in the selected cases. Thank you very much for your attention.
Thank you very much. We are going to be learning about the complications and pitfalls in primary total hip by Professor Tanveer Sadiq now.
Assalamu alaikum, and thank you for the invitation. The aim of this talk is really to know the complications associated with THR, how to define them, how to recognize them, how to prevent, finally, how to manage them. As everybody knows, the THA is a highly effective treatment, and that's why number is increasing. Number is increasing, that means the complication rate is increasing. Although we may not accept it, but we all have the complications during our lifetime. Classification of complications, you can classify them according to the perioperative reason and late complications. Complications, I divide them according to three personalities: personality of the patient, like comorbidities; personality of the surgeon, like learning curve; and then the personality of the joint, like the complexity of it. So your complications will depend on these three personalities. Definition, this is a definition defined by the Hip Society, the AAO's meeting. Grade 1 complications requires no extra treatment and has no deviation from routine follow-up. Grade 2, the complication which requires slight change in care, like outpatient care, extra outpatient care, but no surgical treatment. Grade 3 is complication which requires unplanned surgical treatment and prolonged hospital admission. Grade 4 is a complication where there is a limb and life-threatening, and grade 5 is death. So that's how these are defined. And this definition is basically when you are going to do research paper, that's where you are going to define your complication. Otherwise, you are not going to compare oranges with oranges. Common ones that there have been by the AOs, there are 19 complications which have been validated, associated with total hip replacement. And some of the common ones are these ones. DVT, asymptomatic, and radiological diagnosis is up to 70%. And that does not mean that you need a treatment for that, but fatal PE incidence remains the same, 0.5 to 1%, not changed by any type of prophylaxis. Okay, the regional anesthesia like spinal epidural reduces the risk of DVT up to 50%, and mechanical prophylaxis with or without 75 milligrams good as any chemical ASA1. This was by Oxford group called PEP trial. I was part of that trial. And in ASA 3 and BMI more than 35 and patients who had a past medical history of DVT, they do require chemical prophylaxis. Infection, obviously, urinary tract infection, respiratory tract infection, superficial surgical site infection, they have all been reported, and the prevention is basically strict theater protocol, use antibiotics within half an hour before, and 24 hours recommended minimum. Although I know that since I have started working in Pakistan, 24 hours antibiotics doesn't work. You have to give at least 4 or 5 days. Fracture during and after surgery incidence is 2.5 to 3.5% in uncemented replacements and 0.5% in cemented arthroplasty. And it can happen on either on the femur side or the acetabular side. Again, prevention, learning curve, especially DA, preoperative templating, adequate surgical exposure, special care when cementless process. Dislocation, patient factors, elderly, history of alcoholism, drug abuse, neuromuscular diseases, and again, spinal pelvic interaction. We heard this morning lectures on that. Surgical factors, malpositioning of the implants. Again, we heard about those. Implant factors, small head, low head neck ratio, and built-in 10 degrees liner. These 10 degrees offset liners, they protect the dislocation, and at the same time, they can cause the dislocation. Prevention, restore the biomechanical biomechanics, larger femoral heads, and neck. And this is just to show a case where there is a high hip center and all. Change it. I used the large cup, jumbo cup, and managed to get the hip down, so LLD is down, hip center is fine. That works well. And again, just to say that dual mobility does not always work. Also,
1 minute remaining.
This is spinopelvic interaction. Again, this lady had a total hip replacement for 5 years, no problem. She had a spinal fixation, spinopelvic fixation. She ended up with this. Put a dual mobility. Nerve damage incidence is 6 to 3.5%, again related to the approach you are using, sciatic nerve most common. OC approach, femoral and lateral cutaneous nerve in direct anterior, superior gluteal nerve, operated nerve in anterior lateral, and prevention, obviously, surgical factors. Heterotropic ossification needs to be identified, prophylactic in indomethacin in those cases. Aseptic loosening, polywear, stability, all impingement, iliopsoas tendon impingement, you have to recognize on the table. LD, I think we will learn on the but summary, you have to recognize, acknowledge, and know how to treat.
Thank you very much. I would request Professor Tahir Khan to come onto the stage and tell us about total hip arthroplasty in active young adults and how to navigate about its surgical complexity.
Thank you very much. As always, it's a pleasure to be here to see the friends and share my experience. So I don't need to convince you guys here that arthroplasty is the best procedure invented by orthopedic surgeons in the last century. I think in Lerma and Cecil Rohraback called it the procedure of the century. But you must remember that a lot of these hip arthroplasty in young people, they start their journey very early on as Perthes disease, hip dysplasia we learned about, slipped epiphyseal epiphysis, and many more. And we people like myself, spend our life trying to preserve that hip and try to delay the arthroplasty. So during that process, we offer them all sorts of surgical procedures, both bony and soft tissues. But we also know that 2/3 of the hip dysplasia patients, by the time they reach 30 years of age, are ready for hip replacement. They will have it or not, depends on their circumstances. 1/5 of Perthes disease patients within 16 years of Perthes disease, again in their 30s, would typically require hip replacement. And half of slipped epiphyseal epiphysis patients do the same. And if you look at the National Joint Registry, that's a UK National Joint Registry, 2013 and 2022 data, about 1/4 of all patients would require hip replacement before they're 40 years of age. And that figure has not changed in the last 14 to 15 years. So still about a quarter of patients, and they typically have dysplasia, Perthes disease, or slip femoral epiphysis as the primary reason for that. The outcome we know from joint registries that 90+%, 98% of the patients who are in a standard hip arthroplasty group at 20 years would have a good outcome. And if you look at the New Zealand registry in young patients, they published it recently, about 10-year survival in young patients is about 90%. And the reasons, again, are what we already know: osteoarthritis because of chondrolysis, SUFI, pseudoachondroplasia, and all the conditions which are childhood and they lead to hip replacement. If there's more than one comorbidity, the patients end up staying longer in the hospital. If the patient had previous periacetabular osteotomy, their outcome is not as good after hip replacement as expected in other patients. If the patient have had a femoral osteotomy before hip replacement, the complication rate is higher. This paper from Oxford concluded that the outcome is as good, but if you analyze the data, the complications are usually more related to previous surgical treatment. Unfortunately, we do not have a scaling system to identify the complications. And if I may, this is one of the criticisms of the National Joint Registries, that they do not record the patient complication factors. They now have got a database or a software which analyzes the patients who are coming for revision surgery, but not for the primaries, and there's a need for it. That paper from Oxford again, and they looked at patient age at intervention and the risk of revision. If the patient age is less than 70, they said the lifetime revision for that arthroplasty hip hernia is 35%. So what's the challenge here? Surgeon is usually thinking of patient expectation. They're looking at the previous treatments and the anatomical issues. More important than anything, most of us would be looking at the surgical challenges we're going to face during the surgery. And that includes the approach, the center of rotation and all that, and the implant type and articulation, and the long-term outcome. Patient, on the other hand, is usually worried about the quality of life. And they want to have this procedure once for all and not to have to worry about it. And that's what we faced with. So most patients have these multiplanar deformities. That patient has had 4 previous surgeries for slip femoral epiphysis, retained screws, and a retained broken drill bit there. This patient has had adduction and flexion deformities, so piriformis entry point is not going to be an option here. And when I did do the surgery on a similar patient, I ended up putting the hip too high, and the patient had leg lengthening, which is the commonest source for litigation in hip replacements. And then you have these problems which we talked about earlier. So why does it matter? Because these patients have had multiple procedures, they have a difficult exposure, malpositioning of the implant is a real problem, hip instability is an issue, and they usually have abnormal biomechanics. And we are aiming to correct the leg length, correct the center of rotation, correct the lever arm function, biomechanics, and bone osteointegration. So why does it matter? I normally would have a show of hands here, but in interest of time, I'll carry on. So my take-home message is, this is the one slide I want you to all remember. You need to plan, plan, and plan again. Sarah Muir had always published this data from the Royal National Orthopaedic Hospital where I work, and she said that the long-term survival in these patients after CAD-CAM hips is pretty good. This is one of my patients which had a CAD-CAM hip, and the people who are more observant will follow that we plan to put in a monoblock hip, but we did not. We had to cut the hip short and then put in a fascial Duval rod because the CAD-CAM hip did not fit. So the 2D planning has insufficient representation of the deformity. Accurate planning may not be possible, and implant selection may be inaccurate. So again, this is one of the patients. She is 30 years old. She has had 26 procedures previously, and she literally has no abductors. Dysplasia patient. So again, the observant one will notice that this is not a CAD-CAM hip, it's an SROM hip, but this is what we had planned. Because the patient had multiple deformities, CAD-CAM did not work, and we could not get a custom fit. So again, coming back to planning, my suggestion to you would be, when you do plan, you look at the acetabular anatomy, proximal femoral anatomy, look at the intramedullary callus and medullary canal.
1 minute remaining.
So go for a 3D planning, which involves CT-guided planning, gait analysis, and you look for all those issues that we talked about. This is one very good paper about that, and you can read it yourself. You need to plan for your soft tissue releases as well as the bony deformity correction. So this is a patient which we did do with a 3D planning. We ruled the infection out. The shortening was about 3 centimeters, and we thought we could do that without the shortening osteotomy, and we achieved that. And we maintained all the goals. This is how it was. So when we came up with this patient who was 7 centimeters short, we did the distal femoral lengthening because we knew we were going to shorten it and planned it. So the intramedullary shortening or the supratrochanteric shortening was 7 centimeters. So we did a shortening and we achieved the same. She's now 10 years post-op, She's now 10 years post-op and have 2 children and doing really well. This is unpublished data from Alexis Nogier. Both the acetabular side and the femoral side integrate really well. And we published recently in a teenagers, and we noted that outcome can be very, very good in these patients. This is unpublished data again. We written it up, waiting for the approval. In Crow type 4 patients, the complication rate is about 20%. So you need to be careful with the patient consenting and advise them properly. So in conclusion, you must aim for sequential treatment of bone and soft tissue procedures, shortening derotation femoral osteotomy only if required. Supposition is crucial, plan A, B, and C. And I conclude that total hip replacement with the previous osteotomies is challenging. And my last slide was going to be to invite you to Manchester for BPOS meeting if you're free in May. Thank you very much.
Thank you very much, sir. Doing a total hip after a proximal fracture fixation failure is a great challenge. To learn how to do it, I would invite Professor Afshin onto the stage. Okay. We are going to be moving towards the next talk. I would request Professor Arif Khan to come onto the stage to tell us about spinopelvic alignment issues in total hip arthroplasty and how these issues influence our cup placement in a total hip.
Bismillah ar-Rahman ar-Rahim and Assalamu alaikum and good morning. It's a very interesting topic and I will try to make it as simple as possible. I have no disclosures and I will start with this case who is a 65 years old male. He had a lumbar fusion 5 years ago and he had bilateral total hip replacement 2 years ago. And 2 years after total hip, at one night, all of a sudden while coming out of his bed, he dislocated his hip, and you as a surgeon wonder what happened all of a sudden after 2 years that he dislocated his hip. And in the background, abnormal spinopelvic motion is linked to poor outcome in total hip arthroplasty. About 4.5% of total hip patients nowadays have had prior spinal fusions, which is a 300% increase during the last 10 years. And therefore, spinal surgery has become a strong predictor of THA instability more than dementia and psychiatric diseases. And because of this, there's an increased relative risk of revision with spine diseases. Now, we need to understand certain terminologies before going and understanding this one. And the most important 2 parameters that you need to know is one pelvic and one is lumbar. The most common pelvic parameter that you need to understand and measure in this patient is pelvic incidence, which is a sum total of sacral slope and pelvic tilt. And then is the lumbar lordosis. So normally the pelvic and the lumbar, both these parameters are the same with a plus minus of 10 degrees. If the pelvic incidence and lumbar lordosis are more than 10 degrees apart, this spine is unbalanced. So normally we see 3 kind of alignments, a good alignment, then anteverted pelvis with more hyperextension of the lumbar lordosis of the lumbar spine, and then a retroverted pelvis with compensatory flat back. Now, what is pelvic tilt and how do you measure it? And if you draw a vertical line along the pubic symphysis, it should touch the ASIS. If it touches that, this is a neutral pelvic tilt. If the ASIS lies in front or anterior to the vertical line, the pelvic is anteriorly tilted or anteverted. Or if the ASIS is posterior to that, then it is retroverted. Now, what is the implication of pelvic tilt to the version of the acetabulum? And if you see, this is a neutral pelvic tilt, and look at the acetabulum, which is normal 20-25 degree of anteversion. When the pelvis rotates anteriorly, the acetabulum goes into retroversion. When the pelvis rotates posteriorly, the acetabulum goes into anteversion. So this is a paradoxical moment, and that you need to understand. With pelvis anterior rotation, the acetabulum goes retrograde. With pelvic posterior rotation, the acetabulum goes into anteversion. This is again another picture. The anteverted pelvis, less anteversion, the retrograde, the posteriorly rotated pelvis, more anteversion. Now, we also know that for every 1 degree pelvic tilt, there is a change of 0.8 degrees in anteversion and 0.3 degrees in inclination. So mainly there are two abnormal spinopelvic movements. They are the stuck sitting and stuck standing. And what is stuck standing? Stuck standing is the pelvis is rotated anteriorly, which is normal during the standing, but during sitting, the pelvis is supposed to roll back, go into retroversion, and this kind of pelvis would fail to do that. Meaning that during standing, when it is anteverted, there is less anteversion. That less anteversion stays during the sitting as well. That predisposes it towards posterior dislocation. This is more common in hyperlordotic spine, in severe flexion contractures at the hip, in chylosing spondylitis, and in hip arthrodisc inflection. Then in stuck sitting, the pelvis stays in the sitting position. That is more retro-rotated, more posteriorly rotated. That means more anteversion. When the patient stands, the pelvis is supposed to roll anteriorly. This pelvis cannot. So it has more anteversion during standing, which predisposes towards anterior dislocation. And this is more common in flat back and chylosing spondylitis, and in long fusion, which is done in kyphotic position. Which is the effect on sacral slope? So when the pelvis rotates to the front anteriorly, the sacral slope would increase. When the pelvis rotates posteriorly, the sacral slope would decrease. And normally there is 20 to 30 degrees of difference between sitting and standing sacral slope. If this slope difference is less than 5 degrees, this is a stiff spine. What is a balanced spine? If the PI-LL ratio is less than 10 degrees, this is a balanced spine. If it is more than 10 degrees, this is an unbalanced spine. So based on these two parameters, the stiffness and the balance of the spine, Fan et al. Classified them into 4 groups: flexible and balanced, rigid and balanced, flexible and unbalanced, and rigid and
1 minute remaining.
So the flexible and balanced, this is the normal one. Then the rigid and balanced, it is anteverted, and the recommendation for them is to keep the cup a bit higher side on the anteversion. The unbalanced spine, the recommendation is to restore the balance by doing a spinal osteotomy, and then go for a normal version, or you have to reduce the version. So this is one of our patients with ankylosing spondylitis, severe deformity, and this is stuck sitting position, and we did a spinal osteotomy, restored the balance, and then we did a normal cup version. This is another patient with severe ankylosing spondylitis and with severe deformity of the spine and hips as well. And in this case, we first did the hip. Unfortunately, one of the hip got infected, and we had to do a fusion. In the second, we were able to do it, and then we did the osteotomy, and this is the patient after the surgery. So this is just a summary. All these patients who you think can have spinopelvic abnormalities should have a lateral pelvis view in sitting as well as in standing and check whether the pelvis and the spine is stiff or not. Then the second parameter is you need to know the pelvic incidence and lumbar lordosis to see whether it's balanced or it's not balanced. Once you know these two parameters, then you can fit them in these scenarios, and you can adjust the version of the cup a bit more anterior or a bit less anterior. Thank you very much.
Thank you very much. Very excellent and very nice talk about spinopelvic positioning and the total hip replacement. We will now be moving towards the question and answer sessions. We have 2 microphones installed in the middle of the sittings, and you can come over to that area and ask questions one by one. You should pronounce the speaker whom you want to ask the question to, and then state your question clearly so that these questions can be answered. Yes, please.
Thank you very much. I have one question from Professor Jawad Murtazavi, who has shown us a very immaculate technique of in DDH. I want to ask that he is not doing proximal femoral shortening osteotomy, and conventionally what we understood that the shortening osteotomy which we are carrying out is not to reduce the hip back, it is for the shortened hamstrings and the sciatic nerve pathology. So how do you manage the hamstring shortening?
Thank you very much. That's a great question. Thank you for the question. You're right. We do osteotomy to manage the hamstring shortening, but as I show you, I do shortening, but I do supratrochanteric shortening. As you see, in all of my patients, I did the femoral cut as low as possible. Most of the patient, I remove the proximal part of lesser trochanter. And actually, this is the way that I get this thing. The other thing is, I put the cup a little higher. In the previous, the first series that I show you, I put the cup in true acetabulum. Most of the time when I get the post-op X-ray, part of my cup was in the obturator foramen. It's too low. So this is the another reason. When you put the cup higher, actually I start removing as I show on the ridge, not under the ridge, on the ridge. So this is the another one. You can address the hamstring shortening from this. So you put the cup higher, you go to SM lower, so you can get the same thing.
All right, so what I understood is that by putting the cup slightly higher, you actually manage the shortening of the hamstring.
Yes.
Thank you.
Professor?
Thank you very much, Professor Zaki. Question is two-pronged. Professor Arif Khan from Peshawar and to Antonio. I wanted to ask you, is there a dynamic way of testing the pelvic inclination effect on the acetabular placement when you're actually doing the operation by image intensification? Because we see a lot of cases, and the evaluations that you mentioned may not be easy for every surgeon to do. So when I'm putting a total hip, and if somebody's got a spinal problem, and suppose I realize that during the operation, and I'm just doing the trial of the cup and the stem, is there a dynamic way of actually checking that during operation? Because I remember you showed an X-ray which on the image the cup looked excellent, but still things don't work out that way. So I can use an image intensifier to see that, but later on find out that the cup was not in the right place. Is there another technique, an easier one?
What I understand is that you want to know that if you haven't done the proper planning, you haven't estimated whether the pelvis is fixed or is not fixed, the spine is stiff or is not stiff, and you are doing a total hip, and then you want to know if there any way. I think that would become very difficult, and it would not be accurate. You need to do your homework before going to the surgery. Whenever, like this should become an SOP. Any patient going for a total hip should have a lateral view of the pelvis in sitting and standing. This is number one. And number two, you need to know the pelvic incidence and lumbar lordosis and whether they are equal to each other or they are different. Once you know these two, then you are in a position to know whether the pelvis is stiff or not stiff. Once you decide that this is stiff, and how would you know? When the sacral slope difference in sitting and standing is less than 5 degrees. So once you know that, then you have to decide whether this is stuck standing or stuck sitting. That means the pelvis is in the sitting position or the pelvis is in the standing position. If it is stuck standing, you need to increase the anteversion. If it is the stuck sitting, you need to decrease the anteversion. But there are two important things that we need to know. Are there any hip flexion contractures? If the hip flexion contractures are there, you have to do the hip first before the spine, no matter how severe the deformity there is. And number two, whether the spine is balanced or is not balanced. Because in an unbalanced spine, if you are doing total hip, your cup obviously will go into a different position. Once you restore the spine balance, it will totally change and it might dislocate. So restore the spine balance before you can do total hip. Or then if you are doing primary and if it is stuck sitting, you have to reduce the anteversion.
Well, that's okay because you're doing spine. But most of us orthopedic surgeons are not doing spine. So you showed cases like that. My answer was at a more simple level. Not people who had fixation, but people who had spinal osteoarthritis with limited mobility. Is there a simpler way of testing that? That's
yeah, so that's correct. But the simple way is at least you would know that the spine is balanced or not balanced. And the pelvis is fixed or it's mobile. These are the two things that we need to know.
The other question was for our gentleman from the Philippines, Anthony. You used a short stem femoral prosthesis on your anterior approach, right? And to enhance stability, what was the choice of not doing dual mobility implant?
Yeah, thank you for that question. Actually, those were the succeeding slides I was supposed to show, why I've made a shift from a standard stem to a short stem. And one of the reasons is, one of the complications we've encountered, especially with the direct anterior approach and regular table, is a lateral femoral cortex perforation. Yeah. Mainly because when you try to maneuver your standard broach with a limited view, then oftentimes you can actually perforate the lateral cortex and this could lead to a periprosthetic fracture. And that's why we've made the shift to using a short stem, because with a short stem, basically, the likelihood of you causing a lateral femoral cortex perforation is lower. But then again, assessment has to be made with regard to how adequate your bone stock is, because your short stems normally have a higher medial lateral diameter, and so it should be able to accommodate that fairly robust proximal part in the proximal femur.
And do you plan to use, do you normally use a dual mobility or you don't use dual mobility?
No, rarely have we had to use a dual mobility. The only time we've actually had to use a dual mobility is when we do Crow 4 dysplastic hips. But otherwise, for a straightforward arthritic patient, then usually with a ceramic on poly or ceramic on ceramic articulation, we normally are pretty happy.
Thank you.
Thank you very much.
Assalamu alaikum. I'm Mansoor Ali Khan from Karachi, Aga Khan University. My question is for you, sir, Professor Sanwan. Yeah. I've had a fair amount of experience with total hip replacement through the anterior approach, and my question was that you say you put a sandbag under the posterior superior iliac spine or under the sacrum. We've heard a lot about the spinopelvic relationship and how it can affect, and I've never done that because my concern was that it would change that and it would fool me into putting the acetabulum, which is already hard. I use an angled acetabular impactor and acetabular reamer. Would that affect that, the spinopelvic relationship?
Yeah, although we haven't had, I mean, we don't have the privilege of having a robot when we do this surgery, but basically even after putting a roll or a sandbag under the posterior superior iliac spine, we've noticed that it actually does not affect the pelvic tilt. But all the same, if you notice that there is somehow a difference in your pelvic tilt, I'm pretty sure you visualize the position of you visualize your hips even before prepping the patient.
Yes.
So if you notice that there's a difference in the pelvic tilt, you can probably make an adjustment in the angle of your C-arm as well to make sure you get a true AP visualization of your hips, of both hips,
Right.
so that in the process of verifying your cup position, then you will be able to still target the true AP view of your acetabulum. But the only reason we do the sandbag or a rolled linen under the PSIS was to be able to elevate the pelvis a bit more, because when we hyperextend the hip as you break the table, you need to get that clearance somehow for you to be able to elevate the proximal femur.
Right. Thank you.
Thank you.
Excuse me. Excuse me.
We've got the gentleman there and yourselves then. Assalamu alaikum, Dr. Heather. My question is from Dr. Naeem and Dr. Ismail Ramzi. How would you best manage abductor shortening in Crow 3 and 4 dysplastic hips without causing abductor insufficiency? And is NCS EMG effective in assessing the outcome?
So it's a nice question. The basic idea is to bring the abductors down when they are very contracted. And especially true when you have trochanteric osteotomy and you need to make the tension balance of the abductor lever arm and lateralizing it and distalizing it. Sometimes it comes down very easily, but when the contracture is too much high, you need to release the abductors all the way from the attachment of the iliac crest. This is what we call Campbell's release. And this same procedure is carried out in flexion abduction contracture in polio surgery. So it's a Campbell's release. You remove, release all the way from the iliac crest, the abductors, and try to bring it down so that distalizing and lateralizing of the trochanter becomes very easy.
So does NCS EMG pre-op or post-op has a...
No, it is only during per-operative. If you have the facility, you must neuro-monitor the sciatic nerve. If you don't have the facility, then the simplest way is to have a wake-up test.
My friend.
I'm Dr. Alamgir Khan. My question is from the Honorable Professor from Turkey who talked about replacement in type 4 hips. He talked about very good results of step-cut osteotomies for derotation and shortening. I was thinking derotating a step-cut osteotomy isn't a difficult procedure, and we are also, when you are derotating it, we are distracting the two fragments. So isn't it leading to non-union and things? And how much of derotation can we have with derotation osteotomy in the femur?
If we need how many rotation we can do it, that step-cut osteotomy.
Yeah.
That we are planning to make a proximal osteotomy first, step-cut osteotomy, 3 centimeter or 2.5 centimeter osteotomy. And we put the, that's the fragment, trial, femoral component, trial, femoral head, and we put the proximal part of the reduced acetabular component in. And after that, we make a traction, and we looked at how many centimeters we should shorten the femur. We decided. For the proximal part of the osteotomy, we can do it desired anteversion. It means 10 or 15 degree anteversion on the hip. You know that most of the cases severe anteverted. Because of that, we have to internally rotate it, and we have to do that osteotomy in the direct to the floor. And after that, in the distal part of the osteotomy shot, if we do it posterior, leg must be correct the floor. That's right. And we have to plan that osteotomy, that plan. Because of that, at that time, we can do the rotational type of dose.
Okay, thank you.
Amount. Thank you.
Assalamu alaikum.
Yourselves, my friend. You're first and Badr Bhai.
I have one question related to the Crow 4. Have you have a comment on doing a 180-degree dissection of the soft tissue around the proximal femur and bring the femur down and put the normal hip without making an osteotomy? What is the comment on releasing 180-degree dissection around the proximal femur?
Who's the question for?
Sir, anyone?
Yeah. I never did any release from the gluteus medius from the iliac wing. If we do a resection of the whole capsule, it can come down easily, the proximal part of the femur. But in the soft tissue, release is very important. I have to check. At the beginning, I did routinely adductor muscle release at the beginning. But later on, not routinely I didn't, but if I need, I did the adductor muscles.
So would you prefer to release this 180-degree from the femur only, not the pelvis, only on the proximal femur and bring it down and then put it on?
Yeah, I release that's the gluteus maximus release, a touching there. That's enough, I think.
Sorry, I think what you need to differentiate, and maybe we haven't spent enough time talking about it, the difference in leg lengths can be subtrochanteric and there? Yeah. So you can have a supratrochanteric shortening and infratrochanteric shortening. And you need to differentiate that. Because if it is only supratrochanteric shortening, you can probably release the capsule, the soft tissues, and you can bring the hip down. If it is infratrochanteric, then you need to shorten the femur. You wouldn't come it down. So I think that you need to plan it. And as they say, horses for courses. So if you have the proper planning, you'll know what you need to do.
Did you want to contribute?
Just really want to know from the faculty and all the participants that we heard quite a lot about spinopelvic balance. How many of us do a routine lateral sitting and standing views? Can we raise hands? 2 out of 400 probably, yeah? My feeling is I don't do it. That's why I'm asking this to everybody, that do we do it routinely? My personal feeling is if you are doubtful, just put a dual mobility in. Is that any, yeah, agree, Dr. Shah?
You started
it. I did. You already don't know my answer, so that's fine. I don't think dual mobility is the answer for restoring the spinopelvic alignment. You have to, if you are doing a total hip, that means you have to understand spinopelvic alignment. There is no escape from it.
No, I mean, you're right. But how many of us did a lot of other things 10 years ago or 20 years ago? I think you creating answer to a problem is not creating another problem. If there's a problem, you need to fix that. So spinopelvic obliquity is a genuine problem, and we don't understand it. We didn't understand it until about 10 years ago. And now that we understand it, we need to fix it, I think. And if it's litigation and somebody gets to me and say, well, you didn't correct me, you put the super, I think I'll be in trouble.
So Professor Tahir, I have a point. You see, 15 years back, we were doing hips like anything, and there was no talk of spinopelvic obliquity and everything. So my observation is actually what spinal surgeons have done is that they have started fusing spine like anything in last 10 years. So now, most of the hips that we get, there has been some degree of fusion up. So because it's very strange, you see, we were putting in hips like anything and nobody talked about spinopelvic obliquity and spinopelvic dynamics. And now suddenly there is this buzz of spinopelvic x-rays and pelvic lateral views and sitting, standing, stuck pelvis. So I think the burden is with the spinal surgeons because they have started fusing spine like anything without indication sometimes. Specifically for RF because he does both. So he fuses spine first and then he does x-rays and then he puts the hips, both the hips.
So I'll take the liberty to steer the question back to your friend.
My name is Dr. Nek Mohd and I'm a fellow orthoplasty at Indus Hospital. My question is regarding the anterior hip approach. Usually we see quite difficult to mobilize the proximal femur, and most of the time we end up with the trochanteric fracture. And my question is regarding if we see or found a trochanteric fracture, you have to fix this and how to fix it, either we left it as it is.
So complications during anterior hips.
Of course, thank you for that question. Of course, as much as possible, we try to avoid complications. And like I said, more often than not, the cause for a greater trochanteric fracture when you're doing a direct anterior approach is because you haven't released enough, the internal release of the gluteus medius, such that you're not able to mobilize the proximal femur and get it into good view. So two things can happen there. It's either your greater trochanter retractor cuts through the greater trochanter, or second is you perforate just distal to the greater trochanter because of poor visualization. So which boils down to one thing: to avoid that complication, make sure you're able to really lift your proximal femur and get a good visualization. And this happens with a good pubofemoral release, a good superior capsular release. Make sure you adduct, you're able to adduct your femur towards the contralateral extremity. Make sure the hip is in hyperextension. Never do it in a neutral position. And in that way, you're able to lift your proximal femur better. So it boils down to good positioning, good releases, and a good retractor as well. And second is, you have to remember the direct anterior approach visualization is pretty tight on the proximal femur. The likelihood of getting fractures in the proximal femur is very high. And that's why one of the recommendations I've included, which was not flashed, was rethink doing a direct anterior approach if you have a very osteoporotic patient. I showed you the complications I encountered with one of my patients where I seemed to have pushed my indications. He had a 74-year-old female who was treatment naive for osteoporosis. And so I got fractures from the greater trochanter retraction. I got a periprostatic fracture, mainly because she was osteoporotic already to begin with. So go with your traditional approaches that you're very comfortable with if you have a very osteoporotic patient.
Okay, my question is, like, if we had a complication of trochanteric fracture, we need to fix the trochanteric or just let it as it is?
If it's unstable and displaced, I would suggest you wire it or screw it or put a greater trochanteric hook. Okay. Because, of course, remember, if you have a GT fracture, you compromise your abductor function. Yeah. And remember, that's the basic principle of a direct anterior approach. You're supposedly preserving your abductor function to allow early mobilization. So if you fracture the GT, you need to fix it.
Okay, thank you.
Thank you. Dr. Serena?
Thank you. Just a comment in response about routine spinal imaging. So 5 years ago, I wasn't imaging any spines. And then I started imaging all spines. So for 5 years, we're imaging everybody, as well as their pelvic x-rays. They'd get the standard protocol for their spinal imaging. And it's surprising the number of patients, even those you don't expect, who end up with a red flag because of mismatch between pelvic incidence and lumbar lordosis, or fixed pelvic tilt or obliquity. So I would argue that it is worth doing. Now, you can accept a dislocation rate of 1 to 2% in your practice if you want to, but if you want a dislocation rate less than 0.5%, then you've got to make a change. And the one simple change to do is image your patients. DM cup is not a solution for everybody. It does have its own complications. So being selective and using it in appropriate patients is the right course of action. So worth considering.
Does your navigation and computer tell you about that?
So look, there are two parts to this. One is planning, and that's where you image and plan where you're going to put the cup. The second part is delivery. And delivery can be either patient-specific instruments based on bony anatomy, robots, II. So you've got to plan first and then find a delivery mode second.
Thank you very much. So if there are no burning questions, we will bring this session to an end. Do you have any closing comments, gentlemen?
Well, we had 10 speakers on very difficult aspects of primary total hip reconstruction. All talks were excellent and some confusing. And I think for young orthopedic surgeons, it requires really dedicated training and lot of dedication on the part of the surgeon to do such procedures without going through great difficulties for our patients. Thank you.
Thank you very much. So just some announcements. You'd be pleased to know that there will be no formal tea breaks, but there will be running tea, and you can have those 5 to 10 minute stretch breaks in between sessions. The running tea is behind the partition, Shishmal 3, which is that way. Oh, that way. Forgive me, that way. And then just so the lunch for the foreign delegates will be served where the breakfast was served. So just behind there. And we've got Hafiz Saab to make an announcement with regards to the pharmaceutical industry.
Assalamu alaikum and good morning everyone and welcome to Islamabad. So in addition to amazing scientific program, we also have something else, a formal challenge for everyone to take part. And there are some questionnaires which you can find from the registration desk. And once you have completed the answers, which you can find from various formal stalls, you have to visit them to find the answer. You may not be able to find from AI. And after completing those answers, you leave your completed sheet into a lucky draw box, which is just opposite to this room in the CCL stall. And on Sunday, we will award 5 top scorers. And there are amazing those prizes waiting for you. So make an effort on your break time, do interact with various stalls and find the answers. If you know the value of those prizes, everyone will jump to take part. So I'll leave that one in a surprise. Thank you.
So there's a 5-minute break and we'll reconvene at 10:30. Hello. So I would request everyone to be seated, please. So we're going to move on to the next session, please, which is debates. I would like to call upon Dr. Tanveer Sadiq to chair the next session, Professor Jagdesh Kumar, and moderator would be Dr. Athar Siddiqui. Okay, so debates is the next session. I would like to call upon Dr. Tanveer Sadiq to chair, Professor Jagdesh Kumar to co-chair, and moderator would be Dr. Athar Siddiqui.
Can I please request everyone to start getting seated? People on the left of the hall, if you could make your way to the seats. We're only about quarter full, but in the interest of time, I think we should probably go ahead. Chair, co-chair, happy for me to. Right, thank you. Okay, so we're going to go ahead with the debate session. The first debate is a very common topic on fix and replace for intertrochanteric fracture, something that every orthopedic surgeon, whether in training or very experienced, would still keep seeing, and it is a topic that has been debated over decades now. So for the first part of the debate, which is on calcar replacing arthroplasty, I would invite Tony, with your permission. It was a rather long name, so thank you for shortening that name for me. Thank you.
Thank you, Alter, and pleasant morning again to everyone. So I'm here to talk about why I do calcar replacing arthroplasty for intertrochanteric fractures. So I have no conflicts of interest in relation to this particular talk. But what I would like everyone to know is that actually I am the education officer of AO Trauma Philippines, which means I do fix proximal femoral fractures or intertrochanteric fractures. In fact, the person I'm going up against, Dr. Sial, is also an AO trauma surgeon and also a hip and knee surgeon. But the warning I would want to extend to Dr. Sial is this: we are in an arthroplasty conference and not an AO course. So which means that the sentiment of this room will most likely fall into my favor rather than his. So here is a 72-year-old male patient of mine, fairly active, who does not suffer from severe osteoporosis. So obviously, for most of us in the room, we would probably do a proximal femoral nail anti-rotation fixation for this patient with good results. But mind you, there have been very well documented failures of the PFNA. And the reason there is mechanical failure, usually failure of fixation in PFNA, is mainly because there is pretty commonly a lateral femoral cortical comminution, and as a result, you get very poor reduction, and with the loss of a medial support, these are the three factors that oftentimes leads to failure of your proximal femoral nail fixation. In fact, it has been very well documented. Even documenting the thickness of the lateral wall dictates somehow the likelihood that your fixation will fail. So in situations where we're faced with an elderly male or female who presents with a lateral femoral wall comminution in a pertrochanteric or intertrochanteric fracture, in these situations, I would go with a calcar replacing arthroplasty, just wire the greater trochanteric or lateral wall fragment as well to get stability so that my abductor mechanism is intact. It allows me to make these elderly populations ambulate early without having to give them warning about protected weight bearing.
Who in this room would want their 82-year-old grandmother and tell them that you'd have to do toe touch weight bearing for the next 8 to 10 weeks to protect the fixation? That's very difficult advice to give to your elderly patients. They're already suffering from pain. They already had a fracture. As much as possible, you want them fully weight bearing. And the only way you can get them to fully weight bear is by doing a hemi-arthroplasty or total hip arthroplasty. It has been very well documented that comparing the outcome results of bipolar versus PFNA in intertrochanteric fractures, particularly in unstable fractures where you have a lateral wall comminution, that in this systematic review already of 7 RCTs, the risk of operative failure is higher in PFNA, the risk of reoperation is higher in PFNA, but the Harris hip scores are better in patients undergoing a bipolar hemiarthroplasty. This graph basically shows a significant decrease in the risk of reoperation and failures if you do a bipolar hemiarthroplasty versus a PFNA in an unstable intertrochanteric fractures. So I'll just show you a few other clinical examples of elderly patients of mine who have medial comminution. We end up doing a bipolar calca replacing hemiarthroplasty in these patients. Even in the presence of lateral wall comminution and medial wall comminution, we were able to successfully do it. Severely comminuted fractures like this, lateral wall comminution, medial wall comminution, again, just wiring together with a calca replacing bipolar hemiarthroplasty, you get fairly good results. So why do I choose to replace? Because I have lesser failures and reoperation rates if I do a bipolar hemiarthroplasty. I'm allowed to ambulate my patients earlier and able to weight them earlier as well, which leads to earlier discharge from the hospital. And it's the procedure I would do to my elderly relatives who would have an unstable intertrochanteric fractures.
1 minute remaining.
With that, I end my presentation. We are here to solve problems, not to add to further confusion. Thank you very much.
Thank you. Now to argue in the favor of fixation, I would invite Dr. Shahjahan Sial.
Assalamu alaikum everyone. Thank you, Dr. Athar. It was a very nice talk by my counterpart on this. As he said, I am an arthroplasty fellow along with an AO fellow as well. So this time I would be favoring my fixation part of this presentation. So my name is Dr. Shahjahan and I'm working as Associate Professor in Department of Orthopaedic Surgery, Chanka Medical Hospital, Larkana. As we all know that the fractures of proximal femur are quite common in the elderly age groups of the patients. So PFNA gives answer, suggests a wide variety of complex proximal femoral fractures. So PFNA is again a widely used treating pertrochanteric fractures, and it is an interlocking intermediate device having the 4th generation features. This is the kind of PFNA having the small nails depending on the size of fixation. It's called a spiral blade and interlocking mechanisms. Talking about the indications of PFNA, mainly intertrochanteric fractures, reverse oblique, unstable fractures, unstable pertrochanteric fractures, and intertrochanteric fractures along with shaft of the femur fractures. So here I'm going to show you some advantages of why I'm going to put PFNA in the patient of elderly age group by not replacing by bipolar. So it's basically a load sharing device. So load sharing, we are basically here to salvage the bone. And with the good quality of fixation, it will be early for the patient to put the weights on the partial toe touch mobilization is quite early advised. And this fixation is stable fixation having the controlled collapse mechanism. So to increase the collapse towards the fracture ends to increase the union of the fracture. So it's an anti-rotation mechanism. So it is the lesser chances of failure in fixation of the proximal femoral fractures. It is minimally invasive, so we don't have to go for extensive dissections of to the patients. Patient could be of elderly patient. There is a risk of blood loss, so PFNA just required to just go for a minimally invasive few step sessions to precisely go for this. For this, PFNA is really a kind of a juicy type of fractures for early beginner surgeons in their residency program. So it's basically don't require a much learning curve to go through fixation of the to fix PFNA. It is again a lesser risk of dislocations. So it is a faster recovery level because the incisions and the wounds are quite smaller as compared to the bipolar or any bipolar devices. So it's a low implant failure risk as compared to the bipolar. It has a decreased complications. Very importantly, we are here to preserve the femoral head. In our society, mainly the people are having the proximal femoral fracture, so they impose or they always say that we have to, the population mostly laborer, and they basically go always search for, will I be able to go and squat or work on the ground, or I would be able to perform my prayers or my prayers during that time. And with the situation of bipolar, you will not be able to. It will be difficult for that to go for prayers or any downside squatting works. So femoral head position remains the key, and it's very important for salvaging. Here is some picture of how much the wound is being created for the proximal femoral nail anti-rotation. So it's just a small entry incisions and some 2 incisions for a spiral blade and interlocking mechanism. So here, here are the articles for the comparison of the cemented bipolar hemiarthroplasty versus a femoral nail anti-rotation with a patient unstable intertrochanteric fractures. So the conclusion was that both PFNA and hemiarthroplasty offer comparable functions with outcomes and complication rates. However, PFNA is associated with shorter operative times and reduced blood loss. Comparatively, hemiarthroplasty may facilitate easier mobilization, but at the cost of increased surgical morbidity. And these findings should be guided, individualized treatment, and decreased bias for the patient health status. So there is a comparison of proximal femoral nail with the bipolar hemiarthroplasties. The PFNA and the total hip can both achieve good functional outcomes for the treatment of femoral intertrochanteric fractures. The PFNA offers less trauma and shorter operations, while total hip arthroplasty offers advantages in terms of some rapid functional outcome. But after 6 months, the hip Harris score remains same and very comparable with the
1 minute remaining
and bipolar hemiarthroplasties. So these are the just brief X-rays for fixation of with the PFNA. Thank you so much.
Thank you, Dr. Shahjahan. So we've had 2 really good presentations, one in the favor of replacement and the other one in the favor of fixation. Any questions, comments from the audience? I think still have.
Hello.
So I've got a question for you, Shahjahan, if that's all right.
There's a question.
Oh, is there a question from the audience?
We'll grab hold of it after you're done.
So you suggested that patients in our society or in the Pakistani society would want to sit on the floor, and that's why preservation of the femoral head is really a key aspect of your decision-making protocol. How many people actually do make it to that point after having an intertrochanteric fracture, whereas we know that people really do poorly in terms of their access, ability to return to activities of daily living once they have had a proximal femoral fracture?
Sir, actually, what I'm practicing, what my countries and the traditional status are concerned, the people are more basically concerned for doing prayers, sitting on the ground. Apart from that, if the people are laborer type of home supporting structures, so they need to go down, sit down. In that situations, bipolar will be quite difficult to handle on that situations. And in the elderly age groups, when there are osteoporosis, that will be increasing chances of the dislocations and further complicated during their workplaces as well. Also, in sense of PFNA would be initially, this of course, it requires some kind of a time to get a proper union on that. But after the studies definitely suggest there is after 6 months, the hip Harris score remains quite same for both the bipolar and the PFNA.
Tony, after your talk, do we understand that you're going to replace all the proximal or intertrochs with a lateral combination? Or would you choose some patients who would go cephalomedullary?
Thank you very much for that question. I will make a qualifier for that. I will do it in unstable intertrochanteric fractures in elderly patients.
mainly because the risk of complications like an implant failure and a cutout are higher. So if I have a young patient, let's say a 45-year-old, 50-year-old with an unstable intertrochanteric fracture, I think everybody in this room will still aim for a fixation method. But then when it comes to elderly osteoporotic patients, male or female, I'd probably go for a bipolar hemiarthroplasty. If I may just make a comment with regard to Dr. Sial's comment earlier, remember, what I'm proposing is not even a total hip replacement. It's a bipolar, because we're talking about elderly patients with, the quality of life fairly slow already, which means that they're probably in their 75, 80 years old. So you don't really have to do a total hip replacement for these patients. So the risk of dislocation with a hemiarthroplasty is definitely much lower compared to if you did a total hip replacement. But if you do a hemi with a large head, good implant positioning, I think the likelihood of getting a dislocation is quite low, even if they have to assume the prayer position, because with the prayer position, with a hemiarthroplasty, you can bend the hip all the way up to about 120 degrees, 130 degrees without the risk of dislocation. It's a different story if you did a total hip. But if you're doing a bipolar, then range of motion is not, I think, too much of an issue.
My friend on the mic there. Yourselves, yes, right.
I have a question from Tony. You know that the bipolar arthroplasty in, comminuted intertrochanteric fracture is a technical demanding surgery. Did you consider this difficulty of surgery in your comparing? It is not an easy surgery. It's not an easy bipolar like a bipolar for femoral neck fracture. This is one question. And the other question, did you use cement in your patient or not? Use cement?
Yes, I use cement.
And did you consider any problem of cement problem in this elderly patient that may cause intraoperative death regarding of cement disease?
Yeah, so with regard to the incidence of bone cement implantation syndrome that might lead to an intrapulmonary embolism or death, fortunately, I have not encountered one yet. And the reason I use cement is primarily because of that reason. They are osteoporotic. If I were to use a cementless implant, the likelihood of me getting a periprosthetic fracture is very high. Now, I coordinate closely with our cardiologists and the anesthesiologists as well to make sure that we are able to decrease the incidence of bone cement implantation syndrome. Apparently, the incidence of BCIS increases because of a poor surgical technique, not so much of an anesthetic complication or a cardiac condition. It's mainly because the intraosseous pressure as you deliver the cement is so high that eventually causes the embolism. So what we do is we make sure we insert a feeding tube, a French 10 feeding tube inside the canal, and we deliver the bone cement in a rhythmic pulsatile fashion rather than sort of pressurizing it too fast because it increases your intraosseous pressure, and that somehow has been shown to significantly decrease the incidence of a BCIS.
Just one second, right. by the In way. the interest of time, can we There's a just take gentleman, one sir. last question? Yes, there's a gentleman already here who's asked for it.
My major practice is not fracture treatment. I'm an old guy, but I'm still working. I have used bipolar implant instead of 80–90% of intertrochanteric fractures in the elderly. I even use the remaining part of the broken bones as a bone graft to augment the proximal femur, even if it is non-anatomical. Most of the time use bone cement. I have not encountered any application, and it has changed the life of my patients. So 9 out of 10, I never tell them not to put full weight after surgery. I think it is a great benefit, and it is much superior to total hip because there is really no dislocation unless your surgical technique is really poor. And mobility and weight bearing are the most important things in old patients. And I do get several patients with a failed PFN nail, and I give the same treatment?
Sir, I have got the honor for getting trained under your supervision, so I have seen personally with my own eyes that the way you do such kind of surgeries, the way pre-operatively we say that looks to be very impossible to do with the bipolar and manage those fractures. So definitely I personally learned a lot from that, from you. And as far as my debate was to go for PFNA, so I was kind of favoring the PFNA, but I do love to go for bipolar in that as well.
With that, if
thank
that's
you.
okay,
Thank
we'll
you so
move
much,
on to
both. I think in the interest of time, it's quite a packed program. We need to probably keep moving. There are some more questions, but we'll see if we have time at the end to take them. I know all questions are important. Yeah, in selected patients, replacement has shown to be beneficial. Right, so the next group of talks would be on tribology, and we will be talking about the best bearing surface for a young patient receiving a total hip arthroplasty. And the first speaker is Darren Tay, who would be talking on his use of ceramic, defending that it has the lowest wear rate.
Thank you very much, yes. And I hope to convince the rest of the audience on the use of ceramic on ceramic. But first of all, I'd like to thank Professor Amin Chinoy, Professor Shahid Noor, and Professor Sohail Hafiz for having me over here. The organizing committee did an excellent job in coordinating me coming to Islamabad for my first time, and it's indeed a great honor, a great privilege to be part of this conference. My name is Darren, and I'm from the Singapore General Hospital, and today I'll be talking about ceramic on ceramic in young hip arthroplasties. So first of all, I'd like to submit that the people I'm debating with are all going to propose their own bearing couples, all of which have excellent results. In the literature, the annual clinical penetration rate is 0.01 to 0.02 for all metal and ceramic on cross-link polyethylene. However, when it comes to a hard-on-hard ceramic on ceramic bearing, the literature reports that most of the wear is almost undetectable, with less than 0.01 millimeters per year. And so I propose that when we're dealing with really young arthritics of the hip, this would be the ideal couple. And we've heard of many reasons why we get these very young patients. We've heard of dysplasia. We've heard a lot about how we manage it. Trauma is another big source of young arthritis. And in my own practice, I do see some young patients of 20 to 30 years old presenting with ankylosing spondylitis, neglected slipped capital femoral epiphysis, and avascular necrosis. And the thing that we all know is that these young patients present great challenges to the hip because they are of higher functional demand, they're physically much more active, engaging in high impact activities, and have a much longer life expectancy. Is my time up? Well, I'll just say that we all recognize that there is a great impact of age at the time of intervention on the lifetime revision risk. And in this paper by Andrew Price et al. From the UK, he presented a convincing argument that the earlier we intervene, the higher the patient has for a revision. And if you're doing a male patient with a hip or a knee, at the age of 50 to 54, he has a 30% lifetime risk of revision. Out from the Hospital of Special Surgery, they looked at the reasons for failure in the young hip. And the most common causes were mechanical, of cup loosening, femur loosening, and polyethylene wear. And so just by this alone, you would say that if you don't have polyethylene, then perhaps you may spare the patient from future revisions. And actually, these revision reasons are very different from the ones when we compare them to older patients, in which instability and infection are much more common reasons. So definitely there are some benefits of using ceramic on ceramic bearing in young patients. They have the lowest wear rates that are virtually undetectable in many studies. The wear debris, because of its low volume, does not elicit an adverse response. And additionally, it has a reduced risk of tendinosis when pairing it with a large femoral head. So what is ceramics? And basically it comes from the Greek word ceramikos, which means pottery. And in the hip, we use inorganic non-metallic oxide material principally alumina and zirconia. And it is the features of these contemporary ceramics that make them an ideal surface and material for joint replacement. They are densely packed crystalline structures with strong oxygen chemical bonds, giving them high strength and hardness to resist scratch and abrasion. They're chemically inert, and on the surface they have high surface energy, making them hydrophilic with improved wettability and reduced friction. Additionally, over the many years, there have been improvements in manufacturing, and we've split them into decades and generations. And the most recent generation, which is the 4th generation, which was started in 2003, saw us having the introduction of alumina matrix composite. So we're using an alumina ceramic, and we are doping it with zirconia as well as strontium platelets to increase its fracture resistance and toughness. So what is the evidence supporting the usage of ceramic on ceramic? And we're looking at 10-year survival in young patients less than 60 years of age, a systematic review and meta-analysis of 13 studies and 2,000 hips at an average age of 44 years, and the 10-year survivorship was 96%. In another study on the outcomes of ceramic on ceramic bearing total hip replacements, looking at 4th generation ceramic on ceramic total hips, the survivorship of bearing interface-related failure was 99.4% at 12 years. How about when we compare ceramic on ceramic and ceramic on poly? Now, unfortunately, or fortunately for us, both of these bearings have performed very well, both in terms of survivorship and clinical outcomes. However, there was more detected wear rates in the ceramic on poly group. Fracture risk is almost non-existent with the use of 4th generation ceramics, with a fracture risk of 0.5 over 1,000 patient year in the Delta group coming up from this meta-analysis. But unfortunately, there is some disadvantage to the use of this couple, and that is that of squeaking. And so this is something that has to be conveyed to the patients. And this can occur at about 1 to 30% depending on where you look at the literature. And this doesn't happen on table, so it's not something that you can really assess, but sometimes develops months to years post-operatively. They feel that it's multifactorial in nature. Thankfully, it is usually not painful and does not result in revisions. And so in conclusion, clinical outcomes between ceramic on poly and ceramic on ceramic are similar, with both excellent survivorships and clinical outcomes. Ceramic on ceramic has the lowest wear rates and subsequently the lowest biological response to wear. And fracture risk have virtually been eliminated through manufacturing techniques. Thank you.
Thank you, Dr. Tay. Seems like you're already giving in to the next speaker by talking about ceramic on polyethylene. So I would now invite Dr. Faisal Masood to speak in favor of ceramic on highly cross-linked polyethylene.
Thank you very much. I'm grateful to all the audience and the PAS Society, all the distinguished guests for giving me this opportunity. This is a long-awaited debate with still conclusions to conclude. It was the era started with Sir John Charnley with the concept of low friction orthoplasty, and we then moved on. And it was declared as the operation of the century, which revolutionized many lives with good and excellent outcome. So the determinants of this procedure were the wearing characteristics, the longevity of the implant, and the complication rate. So there are 3 debates regarding the typical metal on polyethylene, which is the most commonly used bearing surfaces, and then there is ceramic on polyethylene and then ceramic on ceramics. So there had been a long debate, and each bearing surface has its own merits and demerits. It's not only the longevity of the implant, but also the cost effectiveness, which in our setup, such as in Pakistan, where most of these patients are from lower socioeconomic groups, and they are predisposed to all those risk factors such as industrial trauma and the use of all these drugs, steroids intake, which make them susceptible to avascular necrosis, along with the addition of all the inflammatory arthropathies, which lead to ankylosis of or arthritis of the joint. So in these high yield cases, where with low socioeconomic group, this variety of ceramic on polyethylene, which is much less cost effective as compared to very highly demanding in terms of economy, the ceramic on ceramic complications, in addition to this cost effectiveness, squeaking and the fracture risk associated with this, make the ceramic on polyethylene combination much better, much balanced, based on either extreme, which is either metal on polyethylene, and other side is ceramic on ceramic. So ceramic and polyethylene combination is much better option and is balanced one. Here is a quick review. The components are well known. The features, the ceramic on poly, wear rate is 0.03 and it is now well established 0.001, but the rest of the features are much in favor of polyethylene. The fracture risk is very low and the squeaking is almost unknown in metal, ceramic and polyethylene. The cost is very, very detrimental because it's in one implant price, you can have two ceramic on polyethylene. And the component availability is widespread in Pakistan as compared to the availability of ceramic on ceramic, in which most of the centers may not be having an idea of this. And revision challenges are less demanding as compared to what it is seen on ceramic on ceramic. So, although the results are comparable, 95 to 98% as compared to 96 and 98% in ceramic on ceramic, ceramic on polyethylene still gives a better outcome in terms as the Harris-Hip score is no more significantly different at 5-6 months, and the comparison of the fracture risk and revision rates and squeaking makes the ceramic on polyethylene a better option. The complications on ceramic are squeaking, the fracture risk, the technical demanding nature of the surgery, and more difficult revisions. While in ceramic on polyethylene, it is with modern polyethylene, all the components of polyethylene wears are almost addressed. The excellent survivorship is well proven. Half the price of the ceramic on polyethylene is half the price of ceramic on ceramic. And there are safe revision and there are almost no chances of fractures. So economical consideration and established longevity of the ceramic on polyethylene, in my opinion, we supported all the scientific evidence. The ceramic on polyethylene is a well-balanced mid option addressing a way balance between either extreme, metal on polyethylene and ceramic on ceramic. The ceramic on polyethylene gives a better, stable and economical option in the current scenario. And it is well backed. If you look up into the literature for searching the best bearing surfaces, all these three surfaces, they merge, and it is in most of these studies proven that the ceramic on polyethylene gives a balanced and well managed, economical, affordable, without any high risk of fractures and squeaking. The metal on ceramic on polyethylene is a better option. Thank you very much.
Thank you, Dr. Faisal. I don't know if you realized you did an excellent job of speaking extempore for the first 2 minutes. We couldn't see the slides. But anyway, that was not your fault. So now we have Dr. Imran Kaisrani, who will now be talking on why he uses metal on polyethylene. Cost matters.
Thank you very much. First of all, I would like to ask for younger population, how many of us use ceramic on ceramic in all the cases? Please raise your hands. I can see only one hand. Okay, okay, two hands. If we talk about ceramic on poly, for all the patients, how many of us use ceramic on poly in younger population? Maybe 5, 6, 7, 8, a few hands. How about metal on poly? I think we have our consensus for the debate. There's a clear winner here. If we talk about the cost effectiveness, we are living in a third world country. We are living in Pakistan. If we talk about statistics, we hardly make two ends meet. The majority of our population can't even afford for the basic necessities, what to talk of the luxury of affording such costly implants. If we talk about metal on highly cross-linked polyethylene bearing surface, the metal normally is cobalt chrome, and the polyethylene that we use is highly cross-linked. One very important thing to remember here is that previously we were using conventional poly, which had a very high and accelerated wear rate, resulting in early failure and the need for the revision. With advances in highly cross-linked poly, with this thing coming up, the wear rates have drastically gone down, though they may not be as low as for the ceramics on ceramics or ceramics on poly, but the differences are not that much either. If we talk about the advantages of metal on poly, we have talked about the cost effectiveness, which is the primary factor when the patient comes to see us. When the patient goes out in search of doctors, first of all, he tries to find out which one of us does this cheap. And then when he comes and sits in front of us, the first question that he asks is, how much is it going to cost him? So the cost is a very important and limiting factor whenever the decision making is concerned, especially in our part of the population. Surgeon familiarity, we know that almost all of us are doing metal on poly, and with the advances in the type of poly that we are using these days, we have much better survival, and we have long-term studies lasting over decades for metal on poly. If we talk about statistics, nearly half of our population is living below the poverty line. And for the remaining half, I was reading an article which said that of those remaining 50%, 80% of those are only one medical treatment away from falling below the poverty line. So this leaves us with a very limited group of population that can actually afford ceramics on ceramics or ceramics on poly. So we have to be practical. Okay, a little bit about metal on metal, although this is not part of the debate, but metal on metal also had decreased wear rate, but for the ions that were released, there were problems with inflammation, pain, potential tissue damage, metallosis, and some risks of hypersensitivity. All right, ceramic on ceramic, there is a category of patient who comes and sits in front of us and they say that just put me in the most expensive implant that you have. So this is the most expensive implant that we have in the market, COC. But the problem with these implants is, the major problem is squeaking. And it's not a very small problem. It's pretty bothersome, it's pretty troublesome. It gives that horror movie feel of a wooden door opening when there's a monster on the opposite side of the door. And this happens for every step that the patient takes. And this is so bothersome that there's a good percentage of patients that are willing to go for a revision for this squeak only. Obviously, there's a high risk of fracture when we are trying to put these implants in and we are banging and sort of impacting them. The head as well as the liner can very well break. The cost, obviously, we have already talked about this. Now, for a ceramic on highly cross-linked poly, it is true that the wear rate is slightly less when we talk about metal on poly, and more compared to ceramic on ceramic. But for the metal highly cross-linked prosthesis, the difference is not that much. All right, if we talk about the longevity and survival at 15 years, I have quoted a few studies here.
1 minute remaining.
For ceramic on ceramic, it is around 94%. And for metal on highly cross-linked poly, it is around 93.5 at 15 years. I think it's not much of a difference to go for an implant that is almost thrice the price for a metal on poly. So summarizing, metal on highly cross-linked poly is an excellent choice, which is durable, biocompatible, and cost-effective, especially in our part of the world, and it sort of remains a popular and well-studied bearing surface. Thank you very much.
Thank you so much, Dr. Imran, and thank you to all speakers for taking on time, hosting to time. We'll take some questions now, specifically pertaining to the bearing surfaces in young hip arthroplasty. Mr. Khan.
Thank you.
Mr. Khan.
Question for Darren, really. Do you think, I mean, as I know from National Joint Registry in UK, the hard and soft surface, which is metal and poly, performs better than any other surface. Are you aware of any data from a joint registry where ceramic and ceramic from a big joint registry performs better than hard and soft? And the related question, do you think the ceramic fracture, especially from the scuff marks, is underreported?
Right. Well, thank you for your question. As I showed from the literature, it's going to be very hard to distinguish between the performances of ceramic on poly and ceramic on ceramic. Both are actually very excellent bearing couples that we can use with very low levels of wear. In fact, metal on cross-linked poly also demonstrates exceedingly low wear rates. And the problem of wear as a mode of failure in hip replacements probably is we're going to see less and less of that over time. In terms of just measuring wear on X-rays, on CTs, looking at penetration and looking at volumetric wear and linear wear, then that is really the only place we can actually distinguish between the two surfaces, ceramic on ceramic being hard, as well as ceramic on poly. Theoretically, the polyethylene wear debris is the most likely to generate out a biological response, right? But of course, as been mentioned by
my esteemed opponents, that level of wear debris is below the threshold, and it's unlikely to trigger a biological reaction like we saw in conventional polyethylene in the past. However, that being said, ceramic wear, they tend to be bimodal in distribution in terms of size, and a large part of them are in the nanometer size, which makes them less likely to trigger off a biological response. So coming from 2 points, the wear particle volume is lower, and the size of the particles also do not elicit so much of a biological response. So that is on the theoretical basis only. And again, like I would submit, if you are going to apply it to a general population, then certainly ceramic on ceramic should not be the bearing of choice. But if you're looking at the really young patients, and I think today I thought that my patients were young, and the presenters before me had presented on patients who were 20 years of age, and they've done series of patients that are under the age of 20, and that's extremely, extremely young. And if we can reduce one revision for them, that would mean a lot to that particular patient. And so is it worth it to spend, and how much is a liner, a ceramic liner, more than a polyethylene liner? In Singapore, it's about 100% more in terms of cost. So it's not really that much more if you look at the entire construct and the surgical fees and the hospitalization fees. And if you can potentially reduce one revision, I think then that would make it worth it. With regards to fracture, right? Again, when you look at the literature, they have all comers. We have second, third generation, fourth generation. The fourth generation ones, if you go to some of these conferences, they encourage you to take a metal mallet, and smash the ceramic heads. And in fact, it would dent the metal mallet more than the head. So I would say that if we are talking about fourth generation ceramics, then that risk of fracture is much less now.
In the interest of time, we'll just take one more question. Professor Rami Soraya.
Sure, thank you. A comment and a question. So the comment first, like Darren, I'm an advocate for ceramic on ceramic over 25 years, and I think the argument of squeaking and fracture has been overemphasized here by the other speakers. 5 squeakers over 25 years, never a revision, and it's fairly benign. Fracture is virtually non-existent, and I think most of the data we have is historical from older stems and older ceramics. But a question for metal on polyethylene. The argument of finances, I understand that. Cost is an issue in certain countries. So I do ask the question in that the example that was demonstrated of metal on polyethylene came with a cementless acetabular component and a cementless femoral component. So if cost is an issue, why aren't we cementing in all polyacetabular components and cementing a femoral stem in?
Does anyone want to take that question?
I missed the question. Any takers?
The standard all poly cemented cup and cemented stem, that's the cheapest. And the outcome in NJRs is probably comparable. And I agree that that's a very good option if cost is an issue. But I think the issue I have with ceramic and ceramic is that we all hammer the head, but we never hammer the cup. And my issue is if you're putting a metal back cup in ceramic liners, and the metal back cup is non-forgiving, and if the liner is not properly fit, it breaks over time. And that's my big issue with the ceramics.
That comes down to technique. You have to have your liner fitting perfectly in parallel. Surgical technique is key. If you're eccentric, yes, the lip will fracture over time. You've just got to get it right.
Right, some interesting discussion there. We'll move on to the next debate, and that's the next thing on the menu. And now we are going to be moving to the femur, and we're going to be discussing cemented versus uncemented stems. So our first speaker is Dr. Gavin O'Neill, who will be talking to us about why he uses cemented femoral components.
Good morning, everyone. My name's Gavin. I live and work in Singapore. I'd just like to start off by saying thank you very much to Prof. Shahid and Hafiz for their invite, and it was great yesterday catching up with my good friend Dr. Mohammed Hanif. He took me around Islamabad and I got to experience some of its culinary delights. So I'm going to talk about cemented femoral components at their underrated champions of longevity, which I would actually disagree with my own title a little bit. I would say they are the gold standard champions of longevity. And unfortunately, I found out yesterday that they're maybe not used particularly widely here. So hopefully by the end of the talk, there'll be a few more people using them. So we can't go into the mechanics of things in too much detail, but fundamentally we're talking about polished taper stems. I've used a particular one my whole life, but they all perform extremely well. They're very cheap, they're widely available, and they just need to be polished, tapered, and colorless. They've been around for 60 years, they've shown fantastic results for 50 years, and they just get better decade on decade on decade, and we'll talk a bit about that in a few minutes. And so what are we doing? We're just harnessing the benefit of those longitudinal compressive forces, loading that proximal bone and keeping it healthy for decades, keeping that bone cement interface perfect, and it gives you fantastic long-term results. Even if you're having an off day at work, you don't put the implant in just perfectly. If it's in a little bit of errors or you haven't quite antiverted enough, it's like the implant knows what to do. It starts to correct itself over the first 12 to 18 months, going into a little bit of valgus, increasing its antiversion, all to get that fantastic load in the proximal femur, keeping that bone healthy. So all the things the uncemented stems say they're trying to do and quite often don't achieve, the cemented stems do, even if you don't do the best job. And like most of us in the room, in particular in the front row, they just get better with age. The biggest issue with cemented stems is not the stems themselves, it's the technique. It's a simple technique that we've been doing in modern terms for about 25 years now. Plug the canal, clean the canal out, fill it with cement and good pressurization. If you do that, not only does it give you excellent long-term results, but it allows you to fine-tune the position of the implant to within a millimeter to give you the best and closest possible results to what you've planned preoperatively. No need for you to be dictated in the stem position by the stem itself. Intraoperative fracture rates and complication rates are much lower, and with that flexibility of the stem, it allows absolute anatomic restoration and hence function postoperatively. They're incredibly versatile. It doesn't matter whether you've got a door A, B, C, whether you're converting a DHS to a total hip replacement or doing a hip replacement primarily for trauma. It's fantastic in all settings. It can be done by juniors incredibly reliably after very little training. Although we have extensive ranges of stems, you actually don't need very many. So in certain parts of the world where things are maybe not complete, you can manipulate things to get you absolutely perfect biomechanical conditions, even using stems that aren't perfect for the patient in size. So just again, with your planning, if you've got a valgus hip, you leave the stem a little bit proud. Perfect cementing techniques, great function, great longevity. If you've got a varus hip, again, preoperative planning, we've heard a little bit about that today. Even without the fancy 3D planning, you put it in the right position, you do excellent cementing techniques, great function, great longevity. So why does all of it matter? Results, results, results. So if you want consistent longevity with excellent biomechanical outcomes, and if you ever really get into the situation where you need to do a revision, which is incredibly uncommon, it is the most simple revision to do. No osteotomies, no blood loss, no modular stems required. Just take the stem out, some more cement, a smaller stem. It's almost like doing half a hip replacement to revise it. The long-term results are consistent. It doesn't matter whether it's designer series, other series from
1 minute
other parts
remaining.
of the countries, whether it's in Australia, Asia, Europe, the results are consistent across the globe. 92 to 94% survivorship at 20 years, depending on what it's coupled with on the acetabular side. 99% for aseptic loosening at 20 years. It's very difficult to beat. If you don't believe me, you look at the non-biased research in the registries and they confirm it across the board. It doesn't matter what company makes the implant, they're all extremely good. So in conclusion, if you want longevity, reproducibility, the most simple technique and excellent results in all age groups from 15 to 90, cemented stems are what you need to use. So don't be fooled by the biological fixation. Spend that extra 10 minutes and get your patients a much better long-term outcome and function. Thank you very much.
Thank you so much. I would now ask Dr. Mujahid Jamil to try and convince us why he does not like cement and why we should not use it.
Thanks very much for the invite. It's exciting, it's wonderful and inspiring here with so many senior colleagues sitting here at the front row. It's beautifully decorated. Thank you very much. For my friend Gavin, I would start with the statement that one size does not fit for all. Does it? Never. So, since the introduction of uncemented hips in 1980s, currently 90% of the hips are done with uncemented femoral stems, especially in US. It's triggered by the discussions well known, cement-induced cardiovascular risk, bone cement interface loosening, and because orthopedic surgeons are always very dynamic, they want to get things done very quickly and efficiently, so they shifted over very quickly to the uncemented stems. Yes, I agree, there was a lot of aggressive marketing and rapid introduction. This is the fact check across the globe. As I said, 93% in US, and you can see in all other countries, the percentage gradually increased over the period of many, many years. So there must be a very strong reason. The consideration, of course, in any total hip procedures, as is for this particular scenario as well, is periprosthetic fractures, periprosthetic joint infections, aseptic loosening and functional quality, and mortality and bone cement implantation syndrome. We'll try to get over these things quickly in 5 minutes. Yes, in uncemented hips, there is an increased risk of periprosthetic fracture, that is factual. Importantly, although cementation has a reduced immediate risk of PPF, its removal during revision surgery in cemented stem is much higher than uncemented stems. The proximal femur morphometry should be assessed, and it has a vital role. Age, sex, and high ASA scores, they are all independent risk factors not associated with cement or uncemented stem, independent risk factors for periprosthetic fractures. Mortality is a difficult comparison because at the moment, all over the world, people tend to use cemented hips in elderly people and uncemented hip in younger people because of the quality of the bone. So then mortality can't be compared in absolute terms, but yes, there is increased mortality in the first 14 days with the cemented hips. That's a fact. And the cementation of femur is associated with a very small but statistically significant increase in perioperative mortality. This is the graph. You can see in the first 4 to 5 days, there is a significant difference in perioperative mortality with the cemented hips as compared to uncemented hips for a variety of factors, but the most common is cement-induced disease. Aseptic loosening on balance in patients older than 74 years of age. It's common in uncemented hips as compared to cemented hips. On the contrary, there are some reports which shows that they are almost comparable. And in some patients, and more than 60 years of age, again, uncemented hips tend to have a greater risk of aseptic loosening. Functional outcome, again, in elderly people, cemented hips tend to have a better functional outcome. They tend to have better stability, rotational control, and Harris hip score as compared to the uncemented hips. Prosthetic joint infection, cement-induced bone necrosis was probably one of the factor to have increased risk of infection. But on the other hand, when we started using antibiotic loaded cement, they said it can reduce the prosthetic joint infection. But the risk at the moment is equal. Special subgroups, femur neck fractures as compared to AVN. So AVN usually happens in younger individuals, as we listened before. They tend to have a good outcome with uncemented hips. And the elderly people, fractured neck or femur is a classic example, large number of hips. They tend to do better with cemented hips. So to summarize, non-cemented hip arthroplasty is dominating and
1 minute remaining.
Are improving. But bone prosthesis interlock mediated by bone ingrowth into prosthetic surface require healthy and regenerative bone stock, which is obviously more common in younger individuals. The immediate stability provided by cementation provides functional advantage in early postoperative period and allows for rapid pain-free recovery and weight bearing, which may greatly benefit people with fractured neck of femur and elderly people. On the contrary, intraoperative life-threatening complications induced by cement, such as bone cement implantation syndrome, may call for non-cemented arthroplasty in patients with morbidity. Therefore, individual patient characteristics should be considered thoroughly when deciding which hip arthroplasty fixation mode is best suited for a given patient. So nowadays we talk about personalized implant, and I think it is very important, but more important is to have personalized decision for this decision-making process based on pathophysiology, AVN, fractured neck of femur, osteoarthritis, tumors maybe, age of the patient, crucial importance, sex, females tend to have osteoporosis more than males, comorbid conditions, ASA grade and functional class, bone quality and osteoporosis, proximal femur shape, we all know DOR classification, and surgeon training. This is probably not mentioned in any paper or is hiding behind the closed doors. The art of cementation versus confidence in uncemented implantation is extremely important. So all these things need to be considered, and then we can make good decisions in favor of our patients.
Thank you so much, Dr. Mujahid Jamil Khattak. I thought you were trained in the UK. You mentioned surgeon's comfort. Have you converted? Thank you, but we can now take questions from the audience.
Very much. I have a question for Gavin about the cemented total hip arthroplasty. Now, my question is that people who are doing frequent cementing in the femur, obviously I see in their lifetime they would have seen the cement reaction in elderly. I do understand that with type C DOR type of DOR C femurs, I mean cement is a better option, but how do you avoid cement reaction in elderly?
So I think it's already been addressed by Tony earlier on whenever he was talking about it in relation to the hemiarthroplasties. I have to say I've done thousands of these and I've never seen it actually. And it's all because of just meticulous technique in clearing out the canal, using the catheter, as he says. I think that's probably the biggest thing. And the only thing I really do is I maybe don't pressurize quite so aggressively in the elderly patients, but apart from that, I don't really change anything. You need to make sure that your anesthetist is on the ball and they have things, you know, well loaded up with fluids beforehand. But I have to say it's actually something, like a lot of the topics we were talking about earlier on in relation to ceramic fracture and other things, it's actually really not a non-event, but an almost non-event these days with good technique.
Yeah. So it's what do you say? Is it the surgeon's work more important or the anesthetist's work more important in preventing?
That depends if anything goes wrong or not. Yeah.
Okay.
If something goes wrong, it's definitely the anesthetist. Yeah.
Thank you.
Right, Professor Sorial.
Gavin, good presentation with passion, but I'd like you to comment on something. There's been an increasing incidence of periprosthetic fracture associated with a taper slip design to the point where recently one of the designs was withdrawn off the market because of UK registry publications. Do you want to comment on that?
Yeah, so I have to say, again, like a lot of the things we're talking about, whether it's cemented or uncemented, I think so much of it is surgeon dependent and your primary training, you know. After your primary training, I think things tend to stabilize. But those first 300, 400, 500 cases that you end up doing, you know, make such a big difference to these things. I think if people are not trained well initially or not in high volume centers, their techniques lifelong are maybe not quite so good. And I think some of those things actually bring quite a bit of issue in and around cement quality, to a lesser degree than uncemented, but the actual stem size and the canal fill probably have they're probably the most important factors in relation to that.
So you would agree then that training is important even for a cemented stem?
It's important for everything. Yeah.
I'm Javed Iqbal, the orthopedic consultant here from Islamabad. Again, Gavin, sorry, you're getting a lot of questions. Continuation of the same periprosthetic fractures. There is certainly a debate going on at the moment, certainly in the UK, about the periprosthetic fractures which happen with the striker and other polished stems. They're more B-type. They're around the prosthesis and difficult to treat. as compared to another stem, for example, a luminous stem, which has got a collar on, and the fractures that happen with that stem, that's also a cemented stem, but not with the same philosophy. The periprosthetic fractures happening with that stem are more C-type, which are away from the stem and are easy to treat. What are your thoughts about it?
Again, in particular, when I was in the UK, we dealt with a reasonable number of, Exeter-related periprosthetic fractures. And then certainly the people I worked for at that stage, we pieced them back together again, wired them together, and, took the stem out and then re-cemented them again. I think I've changed a little bit in what I do, practice-wise, since then. So I would tend to just do an osteotomy now, take the cement out, and just use a long stem, modular to deal with that.
Right, thank you so much. We'll keep moving. So the next debate, we're going to talk about femoral neck fractures in younger patients, personalized management, where it is a gray zone. And Dr. Mansoor Ali Khan will talk to us about why he replaces with a total hip arthroplasty rather than a bipolar hemiarthroplasty.
It's an honor to be here. Thank you so much. I just ran into a last-minute hiccup because I had made my presentation on a Mac, and running on these computers, it changed the font and the formatting. I do not know what's going to come up here. I submitted it 2 days ago. This is a controversial topic, femoral neck fractures in the 50-year-old or younger than 50-year-old. I'm Mansoor Ali Khan. I'm from Karachi, from the Aga Khan University Hospital. This is my institution, and you're welcome to visit it if you're ever in the city. Now, femoral neck fractures and their treatment can be difficult. In these cases, when the fracture is safely fixable with good outcome, that remains the treatment of choice because saving the head is always a good option in the 50-year-old group. In case where the femoral fracture is not fixable safely, replacement of the femoral head is indicated. It is the choice of replacement that remains a matter of debate, and this is why this is often called the unsolved fracture. These are the implants which we are debating. Now, this is an old study from physics, from the Journal of Applied Physics in 1953. And the basic sentence is, volumetric wear is inversely proportional to the hardness of the softest bearing surface. When two surfaces are in contact and have a bearing, if one surface is very hard, one surface is relatively less hard, then the softer surface will wear. And we all know metal is harder than the articular cartilage of the acetabulum. And this is just a diagrammatic representation showing what happens, that the wear, you see that little ditch forming on the lower half, that's what happens when the hard surface is moving against a softer surface. So most of the studies we have are from elderly patients, and some of the data is an extrapolation. But this is acetabular erosion after bipolar hemiarthroplasty from femoral neck fracture in elderly patients who already will have some level of cartilage wear. And this showed a poor outcome. This is among the few studies I found in young patients with isolated fractures of the hip. This is from the Bone and Joint Journal, and it's from 2020. And the conclusion, in the conclusion, they said there's significant reduction in function and quality of life following injury, with all 3 patient-reported outcome measures used, indicating there's a substantial injury. In treatment with hemiarthroplasty or angular stable devices in this cohort were associated with the less favorable hip outcome scores. So this is very clear. If you find this study, you can find it easily on the net, and then you can read it. This is another study which talked about hemiarthroplasty or total hip arthroplasty in recent femoral neck fractures in patients who are self-sufficient, physically active, and basically, in summary, the total hip replacement had a better outcome. Same conclusion from the JAOS. This is a randomized controlled trial comparing bipolar with total hip, even though this is in elderly patients. But the conclusion, marked in red, you can read that the outcome of the total hip replacement was better. Dual mobility was compared with bipolar. Again, the outcome was found to be similar. This is a relatively more recent study from 2021. This has the same conclusion. THA led to highest Harris hip scores and lowest rate of revision surgery compared to bipolar hemi or unipolar hemiarthroplasty. Same conclusion in this study. If you look at the registry data, the Australian registry, now we have, in the case of a partial hip replacement, which is like a unipolar or a bipolar, that 18 years there was a 12% revision rate, while in a total hip, at that same age group, at 18 years, the revision rate was between 2 and 3%, so huge difference. Same report from other registries as well. This is one of my patients in whom I'd opted to do a bipolar several years ago, and this is how he presented with pain 2 years down the line, and when I revised it to a total hip, this is what this patient's acetabulum looked like. And after that, my thought process changed, and I very seldom do a bipolar in a younger active patient. As you can see, the cartilage is all eroded away. I hope you can see it. It looks better on the computer. So in conclusion, fracture of the neck of femur has traditionally been treated by hemiarthroplasty in the elderly. Total hip replacement is reserved for younger active patients. In 50-year-olds...
1 minute remaining.
I'm just finishing. In 50-year-olds, data suggests the results are even more clear in favor of a total hip arthroplasty. The overall outcome is better in this age group with THA. Even though THA may be a longer surgical procedure, slightly more blood loss risk, and the risk of some postoperative instability, the outcome are better in the long term for the greater majority of the patients. Thank you so much.
To counteract this argument in favor of hemiarthroplasty, I would like to invite Dr. Nasir Ahmed.
Bismillahirrahmanirrahim. Assalamu alaikum. And thank you very much, and I welcome all the international and national faculty to be here with us. So obviously, we know that there is more than one solution to a problem. So I thank you very much, Professor Mansoor, to show the data about total hip replacement. I'm going to talk about bipolar. So we know that the burden of neck of femur fracture is huge. But the good news is that the people who are under 50 years of age, in the total burden of neck of femur, they are only 2%. So whenever there is a fracture, obviously, if we are not able to do osteosynthesis, either we will go for a bipolar or a total hip replacement. Now, we must understand that all the hemis are not the same. So we have a unipolar hemiarthroplasty and we have a bipolar hemiarthroplasty. The bipolar hemiarthroplasty has a different biomechanics because there are two articulations. One is the outside with the acetabulum and one in the inside with the femoral head. Now, whenever there is movement, obviously the major movement is between the poly and the femoral head, taking away the burden of friction on the cartilage. And obviously, the wear of the acetabular cartilage, which used to happen with the unipolar, is not the case with the bipolar hemiarthroplasty, making it relatively a low friction arthroplasty and leading to a longer lifespan. Now, if we look at the registry data, it has shown that the revision rates for hemiarthroplasty, bipolar hemiarthroplasty at 9 years is 3.1% in cemented and 5.1% in uncemented. Now look at the NGR data. If the total hip replacement carried out for neck of femur fracture, if you would see over the last decades, is not very huge. Even in 2022, it is about 4.7% of the total hip arthroplasty being carried out in UK. Looking at the American Joint Registry, what it says that obviously there has been a trend of increasing doing total hip arthroplasty of a neck of femur, but still the major portion of the neck of femur are still being treated with hemiarthroplasty. But obviously, I'm not going to deny the fact that the age group we are talking about over here will be better with doing a total hip arthroplasty because of the long-term functional outcome, which is better in this group. So there is another study which actually shows, which has seen the complication of bipolar hemiarthroplasty, and it shows that we have seen that the 15-year survival free of revision due to any reason to be 93.1%, and due to aseptic loosening is to be 97.1%. Now, if we look at the major burden of neck of femur, we know that it's huge. And obviously, if somebody is doing total hip arthroplasty in that, he has to be trained to avoid the complications. But in reality, it is not the real case because the neck of femur is going to come to the nearest hospital. And you may not have that much of trained surgeon there. And if somebody who is not trained in doing total hip arthroplasty properly in a neck of femur fracture, obviously we are going to end up in disasters. Now, total hip arthroplasty, this is the same paper which Professor Mansoor Ali has shown. Now, if you go into the detail of the statistics of that particular paper, they have actually compared the equal cohorts in hemiarthroplasty and total hip arthroplasty, and what they have seen is that the dislocation rate in total hip arthroplasty group is double that of the hemiarthroplasty. And similarly, the severe adverse effects were more than the hemiarthroplasty group. Although the mortality was almost similar, the long-term functional score, the Harris score, was better in total hip arthroplasty. Now, this is from the NGR data, and it shows the revision rate compared for the total hip arthroplasty done for the neck of femur and total hip arthroplasty carried out for osteoarthritis. Now, if we see that obviously there is a slightly higher rate of revision in patients for which total hip arthroplasty was carried out for neck of femur fractures. So in summary, if we look at it, so the dislocation rate is higher in a total hip arthroplastic group, the blood loss is higher in the total hip group, the risk of infection obviously slightly higher, the duration of the surgery obviously is going to be longer, and obviously
1 minute remaining.
And lastly, the cost of the implant is very important, especially in a third world country like Pakistan. So these are the advantages. So what I'm going to conclude is that if you see the burden of the disease, what I would recommend in Pakistan, if a junior surgeon is doing in a 50 years, bipolar would be a good option. And leave the total hip arthroplasty if it fails later on in his life. Maybe if somebody is doing bipolar hemiarthroplasty at the age of 50 years, he might need a revision after 60 years of age. So the person is going to have a revision in both the cases, whether do a total hip or hemiarthroplasty. But a younger surgeon can easily do hemiarthroplasty, can give his patient a predictable outcome, a quicker recovery, and low rate of dislocation and good stability. Thank you very much.
Thank you so much, Dr. Nasir.
Thank you.
Questions from the audience? Professor Shahid Noor. Do we have a mic?
Thank you, Athar, for moderating this session of debate. 2010, and prior to that, Professor Zaki in the Department of Orthopaedic Delegates Hospital, we thought about starting bipolar. Prior to that, we were doing monopolar, and we had many cases of revision either because of thigh pain or acetabular erosion. So we thought about cemented bipolar, and we thought that we will resolve the issue of femoral side failure. And in future, if there is acetabular erosion, we will retain the femoral component and will convert into total hip replacement. Lo and behold, in last 15 years, we've not seen a reason of failure on the femoral side. But the surprising element had been that we have not seen acetabular erosion in bipolar. I'm not talking about less than 50. So it had been a wonderful experience. Initially, the bipolars were done by senior consultant, and then senior registrar, and then residents as well. So level of expertise coming down, but the outcome had not changed. So if there's one message that needs to be taken after this series of debate, if it comes to polyethylene, never use a standard high-density polyethylene. If there's one message that needs to be taken away from this conference is cross-linked polyethylene. Everybody. In USA, standard high-density polyethylene is not available since 2020, 2000, for a quarter of a century. And then technique is important. Gavin has mentioned about cemented, but cementing technique is a dying skill. We, the British trained surgeon, we see we've not been able to transfer that. And in revision surgery as well, there had been very good result with Exeter technique. So good debate, but you are here. I'm so excited. The hall is full up till the end because you have craving for knowledge. And there's been a good debate. There are no more than one way of dealing with the problem. Learn the technique that you will deliver best at your center, in your hospital, in your circumstances. And the circumstances are going to be entirely different, and very nicely said. Thank you. Sorry.
Assalamu alaikum. My name is Professor Ishaq, and I am from Peshawar. Not even in this hall, but in the previous discussions, I'm hearing that in the third world country like Pakistan, we are compelled to use the lower polypropylene and these things, and you can we cannot use the better things, metallic skin. You are compelled to use the metal and polypropylene. So in Pakistan, not everybody is poor. I think there must be at least 10% who can afford. So this is my request to the highly surgeons who can have their expertise. They can import these implants, and they will help these the 10% people. And I think Pakistan will become a star in these cases. This is very bad that we, in every conference, we hear that the third world country. So we must, not only third world country, we must jump up to at least second world country. Thank you so much.
Thank you, Professor Ishaq. I can tell you I moved out of Pakistan 5 years ago, and almost 80% of all hip implants that you can dream of are already available. So in terms of availability of implants, I don't think Pakistan is a third world country. So it is available. Yes, cost can be an issue. But we've come to the end of the debate session. I would ask our chairs to please summarize take-home messages from the very good debates that we've had.
We had excellent debate on the treatment of intertrochanteric. We had excellent debate on the treatment of intertrochanteric and intracapsular fracture nerve. And we also had excellent debate on the choice of bearing surfaces and the stem cemented or uncemented. And again, I would say that not every size fits everything. It's basically, at the end of the day, the decision of the surgeon. The way the decision of the surgeon should be making is what is evidence-based, what is the selection of the patient, and then what's the learning curve of the surgeon who is doing the job. For example, we heard that the evidence base from the registry is cemented hip, but if you are not using the proper cementing technique, it's not going to work. So basically, when you are deciding, you have to decide what is evidence-based, what is your experience, what's the patient like, and then make a decision that this is the treatment we are going to select for the patient. So I think you had heard about all the treatment, different various treatments, but at the end of the day, you have to decide what treatment to be used. Thank you.
Thank you so much. That brings us to the end of this session.
Thank you very much.
Over to you.
Right, just a couple of announcements and then we can move on. So first thing is we've got now the facility to have the Jummah prayers at 1:20 p.m. at Shamadan Hall and additional facilities there. And one more is if I could ask Dr. Yasir Mustafa to stand up. And it looks like he's been to the Palestine stall, so everybody takes inspiration from that. Thank you.
Okay, for the next session of revision total hip arthroplasty, I would like to invite Mr. Tanveer Sadiq to chair the session, and Professor Zamir Sumro to co-chair, and Dr. Saeed Akmal Sultan to moderate the segment. Dr. Tanveer Sadiq, Professor Zamir Sumro, and Dr. Saeed Akmal Sultan, please come on the stage. Thank you.
Yeah, I guess Dr. Tanveer Sadiq would love to take a break. Can we? Shahzad Sadiq, Dr. Shahzad Sadiq, please, if we can have him, please. Thank you. Thank you for pitching in. Just an update to the chair that we don't have the first speaker, so we will start with Mr. Whitwell. Thank you.
Right, thank you very much. We are beginning the session for the revision total hip arthroplasty, which is session 1. I would like to invite Mr. Duncan Whitwell to proceed with his talk, please.
Thank you very much. We're going to talk about bone loss and how we can maybe try and give a bit of an algorithm to understand it. So when you've got a case like this, a young patient, long-term hip, but it's now failed with bone loss, how can you assess this and come up with the appropriate treatment? A treatment that you're hopefully trying to make this last as long as that primary actually did. And that's the big challenge. This is an important slide for everyone who does hip replacements in the audience. This shows your success rate of primary, re-revision, re-re-revision. And you can see that once you get a problem, the problems tend to get worse and compound each other. And we really do need to have the phrase, get it right first time, from the Scandinavian Registry. And the reason is, the bone quality is not great in revision surgery. You've lost that cancellous bone that takes cement. It's brittle. It's thin. These are challenging circumstances for you to get a good fixation of your implant. This is the Proposky classification of the femur. Now, Proposky is the god of revision surgery, and he's given an algorithm and a classification system to the femur, which really sort of does help us. But the femur is relatively straightforward, because the majority of the implants that we use are the modern taper-fluted stems, whether it's modular or not. That seems to deal with most of the stem issues. However, in the acetabulum, it's a different matter. There's a lot of choices. Impaction grafting, cages, etc. Just don't use cement, because cement does not integrate into that poor quality acetabulum, and that's going to give you early failure. We've sort of seen the evolution in the 21st century of the use of porous metal to get much better fixation in that poor quality bone. And there's a number of different sort of systems, all based on porous metal out there. Not just the forerunner, which was the tantalum system, of getting good initial fixation and then getting secondary osseointegration into that. And there's some reasonable studies showing that that seems to be the key to getting that revision akin to a primary hip. And you can sort of see that you get much better mechanical fixation if you do that fixation than you do with lots of impaction grafting, cages, non-biological fixation. And I have to put this, because I think Shahid Noor is coming up and talking about this later, that these big tri-flank cages are also don't quite get the same fixation as maybe the metal porous augments do that we have in our systems. So Poposky's come up with another classification system to try and give us a bit of a steer about how we can revise our hips based on porous augments. He wrote this paper, the acetabular deflect classification, a detailed radiographic approach based on looking at the X-ray and the X-ray alone, not particularly looking at the CT scan, to get a good pre-op plan, a guide to reconstruction, bearing in mind that stability is the key. Good initial fixation, so you're not getting any movement, allowing good primary and secondary osseointegration into the implant. If you do get movement, you're going to get fibrous ingrowth, which isn't going to be a long-term fixation of your system. It's an X-ray based system where you look at the various parameters of where the cup has subsided to and what degree of bone loss you have. I haven't got time to go through all the details of this system, but you know there's 1, 2, 2A, 2B, and 2C, and then the more complex 3A, 3B, and then finally the pelvic disassociation, based on the elevation of the cup, based on whether there's ischiolysis, indicating whether there's integrity of the posterior column, looking at whether the medial wall has been transgressed and that's represented by Kohler's line, and also looking at the teardrop, whether there's going to be still integrity of the anterior column. All these parameters you can nicely look at on X-ray and get an assessment about whether they've been transgressed. And that allows you to then come up with an algorithm about how you can use these porous augments, whether you put them inside the bone in a contained defect, on the bone in uncontained, or actually you put them in different sort of areas where there isn't any bone. So we're identifying where the bone is gone and where the bone isn't. And the bottom line is we're trying to make this so that everyone can do it. Everyone can use this X-ray system and come up with a treatment plan. It's not just the experts on the front row who can do this type of reconstruction. So the type 1 and 2, the 2AB, they're relatively straightforward. You should be able to get a hemispherical cup into those cases. But just to remind you, that bone is still poor quality, porotic, brittle. And so the enhanced fixation attributes of these porous metals on these cups are really good at getting that primary initial fit. The 2C is a bit more complex. There's medial bone loss. And here you can sort of do a technique called the footing, where you can actually put the augments together, a bit like a cork in a bottle. And you can sort of wedge that into the defect, into the medial floor, and that gives a footing type reconstruction, making up the medial bone loss, giving a stable foundation for you to put a cup in with an intact rim. So that's how you can deal with a 2C defect. Getting more complex now with the 3A. This is where the cup has gone up and out, and you tend to have some defect of the rim. And you've got to sort of work out whether you've got a contained defect or an uncontained defect. And here, if you've got a contained defect, you can put an augment within the acetabulum to bring the hip center down. And often that hip center can actually allow the cup to be put on the relatively preserved inferior bone. Or you can put the augment on the bone, again giving you some containment superiorly, getting that third point of fixation and getting a press fit to give you a stable reconstruction. A little bit more avant-garde now, a little bit more complex, a 3B. This is where it goes up and in, so you've got a medial defect as well. And this is a difficult case, and there probably isn't an ascribed sort of reconstruction, but what I tend to have to do is you're dealing with both the superior defect and the medial defect. And this is just a bone model where here you've got anterior bone loss, medial bone loss. You identify the inferior bone by putting that retractor in the obturator foramen, and you build the reconstruction up, building up with an augment superiorly to bring the hip center down to fix it onto that inferior bone, however deficient, and then you can lock it all in with a buttress on the posterior aspect to lock it all together, all with cement between the interfaces to sort of give a good fixation. And then because the inferior bone loss is deficient, I either put cages here and put a cupping cage technique or put inferior scrones to just lock this implant home to make sure we get less chance of any movement and subsequent failure of our fixation. That's the type of fixation that we would try and do in the 3B. Finally, in pelvic discontinuity, that's where you get such a really horrible x-rays. You've got to look for these with a CT scan, so any 3B, you think a 3B does need a CT scan to see if there's a dislocation. Work off the fact that there's an intact soft tissue at the ends of this discontinuity that can be distracted out. And then you can do exactly the same as you've done with the 1, 2A, 2C, 3A, 3B reconstructions. Just do an oversized cup to distract out against the soft tissue at the discontinuity. So my take-home message, before I get the black screen of death, is that modular augments do provide the options to address the majority of acetabular defects. There is an algorithm. It's really based on the Poposky classification, which I think is very valuable to assess your X-ray before you undertake your surgery. Thank you very much.
Thank you, Mr. Whitwell. Now I'd like to invite Professor Syed Shahid Noor for his talk on custom tri-flanged acetabular component with dual mobility liner in acetabular bone loss 3B with pelvic discontinuity.
Thank you very much. I'm extremely grateful to Duncan. He had a choice of coming to a conference to India, matching on the same date as Pakistan, and he accepted our request to come, and we are very grateful. Not only at this conference, but for a long period of time, he's been coming to Pakistan, and he has transferred the skill of biological reconstruction with trabecular metal augment. Using augment and technique, me and many of my friends have been to his center and have learned the skill. So you must understand that what he's doing, there are decades of experience behind. Now we must take one word, and he said that, get it right first time. And we must set up different targets. For example, I said to my team, we should aim for 0% PGI, 0% pain, and we might aim for 100% survival forever. But then revision surgery is an entirely different ball game. And then we must set up a target that our revision should get it right first time. But then there might be second revision and third revision and fourth revision. And then you must be very truthful for yourself. Is this in the capacity of my skill, or is it beyond my capacity? Are there skill and the equipment available? Don't embark on a surgery that has got a high failure rate. So total hip is a very successful procedure transforming the quality of life, and it is available, and the numbers are increasing, whether it be Europe, North America, and in Pakistan, in Asia. But then the other aspect is that the revision is on the rise and will continue to rise exponentially. There has to be revision surgeon, and Professor Tanveer Sadek, my teacher, my mentor, is here, that there has to be revision surgeon who would consistently produce good result. So the rate is increasing proportionately. And I'm just quickly going to go through the classification, and Duncan has given this slide to me. Assessment of the patient is important. Good quality X-ray, CT scan, and identify contained defect, uncontained defect, migration, pelvic discontinuity, and he's mentioned that. Good quality X-ray, superior migration, ischial lysis, collar's line, and then you must quantify on the X-ray the classification of bone loss, but then intraoperatively you have to reassess and reclassify, and most of the time the bone loss is significantly higher than what you had anticipated at the time preoperatively. So your strategy should be available on the OR of a higher bone loss. So finishing here, very good result with Preprovsky 1, 2A, 2B, 2C.
But then we are coming to a different animal when it comes to 3B and pelvic discontinuity. The skill that Duncan had is enormous because he's a tumor surgeon and deals with pelvic sarcoma as well. I'm going to show you the largest series of custom-made triflange acetabular cup. And the reasons of failure are infection, dislocation, and failure of fixation. So how we have dealt with that? A case, 55 years old female, 2007 had the first surgery, 2016 she had a failure, and 2019 she had a revision surgery. So this was a primary surgery, and 2016 she had a failure. She had first revision, where only the acetabulum was changed. Unfortunately, there was a massive failure and superior 3B type of this thing. So this was the first case. We said, look, conventional technique is not going to resolve the problem. So we opted for looking at the literature and we planned for a custom-made plan. So triflange impaction bone grafting, and these are the intraoperative pictures assessing the bone loss. We had a trial acetabular component. We had a trial component of the flange. We have a bone bank, impaction bone grafting. So it's a technique dependent. It is not just the implant. It is technique how you do it. And these are the pictures of the real implant and the placement. And in the series, we have used dual mobility because one of the reasons of failure of these revisions are dislocation. So we are addressing the fixation, we are addressing the dislocation, and obviously we are taking precaution for preventing infection. So these are the immediate postoperative x-rays. It's a bar going into the sciatic buttress part of the bone, which is the strongest part of the ilium. We have a flange on the ilium and pubis and ischium, and this is 3 years post-op, and she's doing pretty well. Another patient, 52 years old. Unfortunately, she's had multiple revision. 1987, first surgery. 2013 years down the line, revision on both hips. And 2011, she had both hip revised. And this is how she presented. And you can see massive bone loss on both sides. She was symptomatic on the left side. And we knew that a conventional technique is not going to resolve the problem. So we planned for a custom triflange cup. And these are the planning. We set the center of rotation, inclination, and how do we deal with the bone loss. So these are planning. And again, we have a pelvic model. We have a model of the implant, impaction bone grafting. So multiple pillar, ilial pillar, and the bar going into the sciatic buttress on the ischium, and dual mobility. And these are intraoperative pictures. And this is how we've resolved the problem. We've retained the femoral component. We've done impaction bone grafting. And you can see it is the biology that on the medial wall, the bone has been reconstructed. If the biology is not restored, this metal is going to fail. Another case, 62 years old female, had a conventional metal on poly. And here, this is a massive 3B bone loss. And this cannot be resolved with simple technique of putting in cement. So again, removal of implant, trochanteric osteotomy, removal of bone, reassessing bone loss, impaction bone grafting, 3D printed cup. This is the outer surface, pelvic surface. So it has to be biological integration of the bone, dual mobility liner, press fit thing, proximal femur replacement. And you can see here, the biology is restored on the medial side, the bone is restored. And this is going to give it longevity. So polyethylene, which is cross-linked, and this is the comparison. Another case, 66-year-old female, had a PGI, massive failure, infected bone loss, 2-stage revision, custom-made implant, impaction bone grafting. So we resolved the issue of infection, we resolved the issue of bone loss, we resolved the issue of dislocation. Last case of this presentation, 72 years old male patient, and you can see here the bone loss both on the femoral side. So it's a 3B bone loss on the femoral side and 3B pelvic discontinuity on the acetabular side. Custom planning, you check, you resolve, you change the planning, and then you agree and you sign, and then you get the implant. So this is again intraoperative picture, pelvic model, impaction bone grafting. You can see the bar here, which provide another pillar of reconstruction. And then intraoperative picture and the proximal replacement with proximal femur replacement. And here you can see the medial wall, the biology has been restored. You can see it clearly here. So we are going to publish in Hip International the largest case series of custom triflange from Southeast Asia. We've had our share of complication. Out of the 15 patients, 2 had dislocation. 1 required closed reduction, 1 required open reduction. 1 patient had transient sciatic nerve injury. 1 patient. So in conclusion, acetabular bone loss, 3B, and pelvic discontinuity present a challenge to arthroplasty surgeon. 3D printed triflange cup is a game changer and essential tool for revision arthroplasty surgeon. This provides a unique opportunity for interaction between the arthroplasty surgeon, engineer, and manufacturer. The use of 3D printed implant will rise exponentially if the price could be reduced, especially in developing countries. And thank you.
All right, thank you, Dr. Shahidnur. I would like to invite Mr. Shahzad Sadiq for his talk on the recurrent total hip arthroplasty dislocation, evaluation and stepwise approach.
Well, we are uploading acting the one question for them. We missed the talk on impaction bone grafting, and we've seen some of the very difficult cases shown by Professor Noor. Duncan, what is your experience of fixing uncemented stem into host bone versus a bone graft added bone? Do you still use bone graft to rely to fix your uncemented stems, uncemented cups in very difficult cases?
No, I don't use the traditional impaction grafted as described by Exeter. Yeah, you've got some voids, etc., that you're going to sort of fill with a little bit of bone graft, and I tend to use some artificial substitute. But you're trying to maximize your host bone construct. You're trying to get as much host bone touching that porous metal as you can. So you want to try and get as big as you can and to try and load that bone. That's just tremendous, that 3D printed implant that Shahid showed, how he got that bone to heal. Because, guys, we're not just dealing with an X-ray, a static bit of bone. We're dealing with a dynamic organ. And to bring that bone back to life needs loading bone. So I don't want a lot of bone graft there that's going to be at the interface of the implant and the bone. I want to just use it for some voids, but then load the bone. I think I can do that with these these intraoperative custom implants that I do. Shahid, how you got that bone to load with those big triflanges is great as well, because that's my concern, that they're sometimes so big and bulky that they might stress shield, but you've got some great integration there. If you get integration, that implant should not fail, should it? If you don't get integration, your screws eventually will fracture.
And as Duncan has said that if biology is not restored, your metal is going to fail. And Professor Zaki is there. In a primary fracture, when you fix, there's a race between fracture union and implant failure. And this is going to apply to our arthroplasty reconstruction as well.
So my experience is there is a fine tune that between how much bone graft you can use in difficult cases, that uncemented cup has to rely on the host bone. Because I have seen in my own hand some failures if I relied more on the bone grafted bone with the use of uncemented in type 3+ defects. So I'm going to talk today and focus more on recurrent hip dislocation. I'm Shahzad Sadiq and I practice in Worcestershire. So if Andy Murray is going to have a hip replacement, what will he choose or his surgeon will choose? Top class athlete, high performer, if we do the survey, they have chosen ceramic hips. And that's what Andy Murray chosen. Having said that, large head does not mean that it will prevent dislocation. And we saw when hip resurfacing reached a peak some 10 years ago in United Kingdom, hip instability was emerging as a major problem with the use of metal-on-metal hip resurfacing. Instability or subluxation is more difficult to diagnose than a frank dislocation, which is obvious to everyone. Ceramic on ceramic bearing hip resurfacing is still being used for very high demand patients and athletes by experts in United Kingdom. Obviously, if you sell your implant saying it does not dislocate, it is good for the patient and the patient will be attracted. And bipolar or dual mobility implants give you added advantage of motion at two interfaces and increasing the jumping distance, which reduces the risk of dislocation. And so does the large femoral head. Having said that, all hip surgeons will experience hip dislocations in their practice. So I hope the cases which are shown by Professor Shahid and Duncan Whitwell do not come to you or me. They have to send it back to the original surgeon for dislocation. For the fact they spent 4 hours or 3 hours on those difficult cases, and they had the first-hand knowledge of the problem faced at the time of that particular revision. So the message which was given by Professor Noor, don't take on very complicated cases unless you have experience. In this talk, we will talk about mainly recurrent hip dislocation and what is the threshold for a surgeon to revise his own hip. It is also noted the threshold may be different once it comes to your own revision than revising somebody else's hip if it pitches up to somebody else's clinic, because in United Kingdom, every surgeon's record when it gets revision gets recorded into the National Joint Registry. So for the last 20 years, I know exactly how many of my patients have been revised for hip dislocation, up to date to April 24, when data is published and released to the surgeon. We will also discuss the causes, and some of the causes have already been beautifully presented before, and we will skip for duplication purposes. We need to look at the factors leading to hip dislocation. In assessment, we had good talks about spinopelvic instability. That probably is a major factor that we still see hip dislocators coming as they get older, other than dementia. And in the management section, we will think about whether a recurrent dislocator can be treated with non-operative methods or with surgical techniques. Obviously, high-risk patients are those high-demand patients, and we already discussed that patient factors should be taken into account. And the easy way to group will be to look at the patient factor, surgical factors, and implant-related factors you are using. And we have to add what we learned, that surgical techniques and surgical experience will also play a role in the use of approach, implant, and surgical factors will come into play. In simple hip dislocation, with the modern use of modular implants, one can change and change the insert to a different insert, change the head size. I still believe if you have an option and you are the revising surgeon, you get the best chance to assess the cause of instability if you are reducing that hip, because you will spend time, you will have the opportunity to assess that joint under anesthetic. So if you are a revision hip surgeon, make yourself available to reduce the hips which may come your way, because you will get a very good first-hand experience that the cause in this particular case was laxity, subluxation, which can be amended. Operative option, as we discussed, could be simple options with the modular implants that we are able to change some liners and the head sizes. And we have now available bioball type implants which allow the ability to increase the offset and the length in the modular heads. Dislocation in my own practice, I have done a hip on this lady on the right side, which I thought was open, but it hasn't dislocated. And 5 years later, I have done a hip on her left side, and which has dislocated and caused recurrent dislocation leading to revision. In this case, we opted to have increased offset, and we opted to change the implant socket to a more inclined and less anteverted. A similar case where we change the version of the implant and change the head size and we revise the socket. Aging population means there will be poor compliance, which means you have to use constrained liners. And sometimes patient is unlucky. His first surgery goes wrong as intraoperative fracture, very typical of uncemented stem, definitely higher. So one case for doing cemented stems, and dislocation that may be due to poor surgical technique, multiple dislocation in this patient. And sometime, because of this, the problems are multifactorial. You are dealing with a patient, in this particular case, bone loss, infection because of previous operations, hence a two-stage procedure of dealing with bone loss, infection, instability, and use of a dual mobility cup. More difficult cases, you can use augment. I opted in this case not to use a dual mobility because we felt that I brought the center of rotation down and addressed the bone loss. So in a sense, we will go at the end to last few slides. Some years back, we were relying on intraoperative positioning, but we all know that the patient are high demand and we may have to come up with more individualized approach. We have to improve surgical technique and master surgical techniques. And probably robot is going to give us that intraoperative feedback that is required. What Professor Idris was asking, what can I do if I feel that there is an issue? Robot and the feedback from CT scan will give you that information. The CT scan probably will be the gold standard for a lot of investigation in future, because true anteversion cannot be accessed by plain X-rays or any other X-rays. And in a sense, the robot gives you a lot of options to assess and map. When I went to the robotic course, I spent more time mapping the acetabulum, so I understood more about the acetabulum, and that information goes to the robot. And that's the last slide for you people to look at while we finish.
All right, thank you, Mr. Sadiq, for your talk. Right, I would like to invite Dr. Pervez Hashmi, and our apologies for this sudden change in sequence. He'll be giving a talk on total hip arthroplasty in acute acetabular fractures.
Then another extension of a total hip replacement, especially in a complex case. Nowadays, a lot of acetabular fracture, and we do see a lot of acetabular fractures. And conventionally, I would say the acetabular fractures happen to be in a two patients population. One population is that of active young patients who actually sustained road traffic accident and high energy trauma, and they have a good bone stock. While on the other hand, there is another group of patients, which we normally call geriatric population patients. In those patients, there's a lot of osteoporosis and existing comorbids along with some osteoarthritis. So here, quality of bone is poor, and those group of patients, they actually require an optimum care. And how we can provide this optimum care in these patients? You see, open reduction for acetabular fracture is definitely deemed to have a certain complications. And we know that in an older age group, there can be a fixation failure, post-traumatic arthritis, heterotopic ossification, osteonecrosis. And we know that the incidence of a subsequent osteoarthritis in these patients, it can go up to 44%. And most of these patients actually require a total hip replacement, maybe a year, 2 years, or few years down the line, once their activity is limited because of a secondary osteoarthritis. So surgeon is actually left with the dilemma, either he has to fix it or he has to replace it. Now there is a paradigm shift. Previously we used to do that we fix it and wait if the patient develops an osteoarthritis, then we are going to replace it. But nowadays, there is a clear-cut indication in certain group of patients which require fixation and at the same time replacement of a joint. And those patients of group, they are specific patients. And specifically in these patients, you see the treatment options which are actually encountered, they are very, very limited. And objective of that treatment is that we need to give a stable construct of acetabulum to start early weight bearing so that patient can go back to his normal activities. Second, if you do actually single shot surgery, these patients, they have a very low reoperation rate and complications, they are very, very less. And then lastly, you avoid actually complication of fixing these fractures. And those complications, we know that there's a post-traumatic arthritis, implant failure, loss of reduction and subsequent refixation may be required. And if those patients, they are confined to the bed for a longer period of time, they may develop deep venous thrombosis, subsequently pulmonary embolism, decubitus ulcer, UTI, and other pulmonary complications. So to avoid all those complications, the best would be to do a total hip replacement once these patients, they are actually optimized. Because most of these patients, they have actually associated comorbids like diabetes, hypertension, ischemic heart disease, and you need to give it just one single shot. And the specific indication for those patients, they are acetabular fractures where there is existing already hip arthritis. Now, acetabular fracture along with the fracture of a neck of femur or head of femur, elderly patient which have a very much accumulated acetabular fracture and there's a lot of osteoporosis and you are not going to fix those fracture and the fixation would be difficult. And especially perioperatively when you feel that you will have a lot of accumulation and the fracture pattern is such that you cannot restore the anatomy, here you will think of doing actually replacement after fixing such fracture. Then there are certain acetabular fracture where there is an impaction, especially in the weight-bearing dome, and there is a lot of bone loss, and you need to actually replace that bone loss, and luckily you have a femoral head to do some impaction bone grafting and replace that loss, and at the same time to do hip replacement. So the timing is very, very important. If it is done within 3 weeks period of time, we call it as acute total hip replacement. But most of the time, if you do an after, it is late or delayed hip replacement surgery. So the prerequisites, they are very, very important. You see, acetabular shift, doing a total hip replacement in an acetabular fracture is not an easy job. And it's not for the young orthopedic surgeon. Surgeon who is going to execute such procedure, he should be familiar with a Rivian arthroplasty, or he should have an expertise in Rivian arthroplasty, along with a lot of expertise in acetabular and pelvic fracture fixation. Because once he is familiar with those kind of a fracture fixation, he can do a better job. Along with expertise of a surgeon and experience, we need to have certain gadgets, and all those gadgets which are required, especially for a Rivian arthroplasty, fixation, augments, they should be available at the time of surgery. So Dr. Shahid Noor talked about 3D printing and those stuff. You see, we cannot have those immediately available within that period of a time. So you need to have those cups which are available with some triflanged dual mobility cup or with a trabecular augments if they are available, those you can use them. So to determine the morphology of fracture, you need to have a good X-rays, 3D CT scan with a 3D reconstruct, so you can have a proper planning to execute that fracture. And perioperatively, you can actually encounter a lot of difficulties, especially because of a distorted anatomy, bone loss, severe osteoporosis, and here occasionally you may encounter the pelvic discontinuity when there is a fracture of both sides. So once you have planned this kind of a fracture, the approach is very, very important. Normally we know that commonly we use Cocker-Langenbeck approach, but depending upon the fracture configuration and the nature of injury, you can do either anterior or combination of both approaches also. And at the same time, one has to be confident that he is going to reconstruct acetabulum. Circumferentially, he should have a 360-degree exposure, and along with, he should protect the sciatic nerve. So assessment of a fracture pattern, you see there, you can see certain cavitary defect, medial wall defect, and severe comminution. But the most technical, two most important points they are that you should have some good quality bone at the level of anterior superior iliac spine and at the level of ischium, where you can wedge in your acetabular component, while the anterior and the posterior wall, they can be reconstructed with those bone grafting. So these are the two important points which you need to know. Then once you have prepared your anterior posterior column and you have reamed the acetabulum and addressed all those bony defects, then you need to implant your cup. And the cup should have a adequate fixation, at least 3/4 screws, especially at the level of anterior superior iliac spine or in the gluteal area or in the sciatic buttress. And maybe you can actually put a couple of screws at the ischial side and the superior pubic sides. So I will just actually skip a couple of slides. And pelvic discontinuity, especially in a transverse fracture, when you encounter, it's extremely difficult to handle. You may have to do two incisions, anterior and posterior, to address that. So if you look at this X-ray, it looks benign. It is after a dislocation once it has been reduced. And this lady had a pieces of peroneal component of a nerve. But looking at his CT scan, you can see there is a split in the head, and posterior-superiorly acetabular wall, it is gone. And another view, you can see here, another view of a CT scan where you need to reconstruct the acetabulum first and reimplant the cup. So this is the result where the posterior wall, it was addressed, and the bone defect,
One
it was
minute
addressed,
remaining.
and then this case was done. So I will just rush through a couple of case example. Another case, almost similar. You can see here, first reconstruction of a posterior wall, and then you see implantation of a total hip replacement. And other case where you see there is a central defect, and primarily with the bone grafting this was done. This is an interesting case. He came from Punjab with a 2-week-old injury, and you see there is a split in the head and the acetabular wall. I will just rush through these slides. I had to do two approaches, anterior and posterior, to reconstruct the both columns and then do a total hip replacement. He remained all right for 3 years period of time. Then he had a fall and had a periprosthetic fracture. So then again, it was addressed within a longer stemp and a trochanteric plate. So I will conclude that total hip replacement is a reliable option in the management of acute acetabular fracture. It is surgically challenging and demanding. It may require additional fixation to support acetabular component within the columns. So current literature actually supports that primary hip replacement, if a surgeon is expert enough, he can do in specific group of patients who had a comminution, transverse fracture, or posterior almost hemifracture and both column fracture, and occasionally when you encounter pelvic discontinuity. Thank you.
All right. Thank you, Dr. Parvez Hashmi. Would like to invite any questions, please.
Question to Shahid Noor. Shahid, just an observation that we heard a lot this morning that Pakistan is a third world country. Heard it a number of times. I think the correct term is developing nation rather than third world. But we also heard in one of the debates how you couldn't use a ceramic head because the extra $300 or $400 that might be involved. Yet I saw one of the biggest presentations from you just now of implants that are really first world nation, because each one costs about $20,000. So how do you rationalize the paradox that's obvious here between going from metal head to ceramic head and using triflange components? Is he here?
I think Professor Shahid Noor has got his management cap on right now, but if somebody could take on the cost analysis between two different countries, well, Prof. Sorel says it's kind of cheaper here to do it.
Professor here. Professor Noor is here?
No. He's on his management cap and he's shouting at people outside. Any takers on that? Yep, there you go.
I'm from the same department, so I have a right to take it. Now, Shahid has got an expertise in this, and the cost does come into account. And this is the selected cases in which he had to go out of his way, get the funding done to solve the problem. So, no, this is not the common thing. In a normal setting, in any hospital in Pakistan, this would not be possible. Let's be fair about it, okay? So yes, he got the funding for it, he went there for it, and he got everything done himself. But he's a very hard-working man in my department, and he does all of these tricky things. That's all I can say. I have full praise for him, for what he's done. But this is not normal. If this patient would have come to any other hospital, funding would not be available for this. We all know that. This is a fact. This is a reality of life. Yes, we are not a third world country. We are a developing country, and we're almost there. Thank you very much.
Just a quick reply to the cost issues. So even in United Kingdom, where you could say that cost is taken into account because the volume of operations will matter. In the National Joint Registry, we have not seen that ceramic on plastic bearing for 70 plus has superseded metal on plastic bearing. So probably we are increasing the use of ceramic heads in United Kingdom. In UK, the cost of ceramic head is around 450 versus around 250 for a metal head. But the cost does matter everywhere where there will be issue with the funding and overall cost. So the question is whether for majority of the patients, metal on plastic bearing at such an age lives that hip. Whereas in a younger population, we see in National Joint Registry under 50, most people are using ceramic on plastic. It is 50 plus in United Kingdom. But cost matters even in well-advanced countries.
Just a reality check here, Rami. Coming into the bracket of the LMIC countries, the multinationals do give us a cost advantage of implants here in Pakistan compared to the developed countries. And similarly, if you look at the current market here in Pakistan, a lot of the Chinese implants are coming in, which are way more cheaper than the multinational Zimmer and J&J, Depoy brands. So I think that also gets into the consideration when we are talking of large number of joints, which are actually that are being done here in this country, and now also of Chinese origin more than the, as well as rightly pointed out, a lot of the places where these arthroplasty joints are being done, it's either some of them are private sector, but a lot of them are government sector, and many of them are charitable institutes as well, where funding is procured for all these individually and on a collective level as well.
Just on a personal note, my mother had her hip replacement done for £13,000 in the UK, and it's about 58 pounds here.
And also, we've got to also understand what the cost of failure is. Yeah, if you've got to put an implant in and it fails within 5-10 years, what the cost of that is. So I think this implant, with the fact that additive layer manufacturing, these custom implants are getting more widespread, more implant companies are able to use that technology. I think that this is probably going to be the thing that's going to give this patient, hopefully, a revision akin to a primary.
Right, thank you. Any other questions? No. I would ask the chairs to conclude the session, please.
This last session, we had a talk from Duncan, who presented his classification on acetabular bone loss. We missed the talk on impaction bone grafting, which basically means how to restore the bone. But we looked at the x-rays. Shahid Noor shown pictures where he has used that technique in his cases to constitute the bone. The trend is that we are putting more implants in, and the trend is that we are putting bigger implants in, and they are replaced by further bigger metal work. The key question in very difficult cases is, first of all, that who should be doing it. And in United Kingdom, we are analyzing the data from National Joint Registry, and that is a good audit tool. It is restricting the surgeons who do less than 50 hip replacement or knee replacements not to do those joints. It is restricting the surgeons who do less than 10 revision hips or revision knee not to do revisions. And multidisciplinary setting is coming up more often, and we are all part of a network where majority of us who work are connected to a tertiary network where we will transfer cases. So the take-home message is still there is a lot of surgical techniques coming up and evolving. They need to be well established. Yes, anterior approach has advantages, but if a surgeon does just 1 or 2 cases per year, it is not sufficient. Similarly, majority of the surgeons use techniques which are easily transferable. So you have to have techniques which are transferable. In reconstruction of acetabulum, Duncan has admitted the femoral side is easily dealt with the implants available, and we see less of a problem. Acetabular side gives problem where there is a significant bone loss. I still haven't got full answer to why we say 3 centimeter or 2.5 centimeter less. What's the basis of that classification? Why not 1.5 or why not 2? But definitely 2 to 3 centimeter is a bigger bone loss, and people should be carefully analyzing those cases and referring to the centers, to the surgeons who have done it before. So master your surgical technique. Think before you do your joint replacements. Stick with the basics and what you know, and analyze your own data. But the future is going to be more use of robotic and AI technology, which everyone is using on their phone.
Thank you very much. We wrap this session up. Thank you so much. Thank you.
Right, thank you.
Just some refreshment on announcements. So lunch will be served at 1:40 p.m. In the Angan and the Kahkashan Hall. But again, for the faculty, it's just behind these walls. We've talked about the facilities available for Jummah prayers. That's 1:20 p.m. at Shamadan Hall. And we'll reconvene 2:20 p.m. Oh, just one more thing. Has anybody forgotten their phone? It's on the podium. So I'll just hand it to the audiovisual team there if some, oh, it's yours, is it right? I'd love to invite Dr. Kazim Rahim Najad to take over for the hot seat session.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. So now we're going to take you through this hot seat session, and we're going to have a half-an-hour session. We try to cover the controversial topic in arthroplasty. For that, I will go to request my esteemed faculty to come on the stage. First of all, Professor Zaki Idris, my mentor, my teacher. Sir, please come on stage. Then Professor Rami Sorel from Australia. Thank you very much, sir. Please. We have Dr. Darren Tay from Singapore. Is he around? Dr. Darren Tay. Okay. So I request Professor Ismail Ramzi Tuzan from Turkey. Thank you very much, sir. And last, I will going to request Mr. Tahir Khan from UK to please come on stage. So thank you very much. We're going to start it directly. So these are the faculties. So we will going to ask few of the controversial topics from them and then see what they have to answer for about it. So humble request to the faculties. These are the few of the rules of the game. Be very brief. We can be answered by with yes or no, and later on we can develop a consensus with the hand raising. So the audience will be also be a part of it. So first of all, enhanced recovery after surgery. So I will start with Professor Rami Sorel. So sir, what percentage of your practice you follow ERAS protocol?
0%.
Sorry, sir?
0%.
200%. 0%. Okay, sorry. So, sir, what about you?
Yes, 0%.
0%. Mr. Tahir Khan? 100%? So, Tahir Khan is going for 100%. Okay, sir. Professor Zaki, I know, but sir, you answered it. So, we can have a mic for Professor Zaki.
We don't, 0%.
0%. So, do you agree it will have better clinical outcome in the early and late post-operative period? I will start with Professor Dr. Tahir Khan.
Yeah, it does, and I think it's well proven. Switched on. Yeah.
It's for early and late, yeah?
Yeah. So
okay.
it's well proven. It's well proven by published data as well as my own personal experience. And more patients obviously want to go home quicker, get back to their activities quicker. So I believe in it, and we tend to follow as a group.
So Mr. Tahir Khan goes with the pros, sir.
Yeah.
So
yes,
what's your comment?
Yes, I
yes,
believe that
you believe it has a good outcome.
Yeah.
Professor Rami Sorel, sir. You say it's 0%, but still.
Yeah, so you wanted us to be brief, but
yes.
When I said 0%, I employ a lot of the protocols in ERAS.
Okay.
But my patients don't want to go home. They want to go to a very nice rehab facility for an extra 2 weeks. So it kind of rubs out the whole concept of ERAS. But a lot of the principles in ERAS for pain management, anti-inflammatories, early mobilization, early weight bearing, they're all good principles.
Okay. Professor Zaki, do you believe in this?
Yes, I agree with what Rami said. Our patients, pain management is important, rehab is important, so they would like to stay with us for a few days, and then we have to be sure as well, because for us, wound inspection is very important before we let them go home.
So, Mr. Tahir Khan, the whole of the light is on you now. Is this protocol can be implemented in every place and any case? Why I'm just asking of this question? The disease that we are facing, it's a lot of different than the disease that you are facing. Or because of the socioeconomic status of our people, financial burdens, of course, the education status, that what we have, it's very hard for us to implement this ERAS protocol. Sir, what do you have to say?
This on. Is it?
Yeah.
Is it?
Yes,
right.
it's working, yes.
Okay, yeah. So I think I'm in a slightly fortunate position that I work in a national orthopedic hospital where facilities are there, protocols are set, and the process is already sold out to the whole group. So everybody kind of accepts it. Sorry, it's me. Everybody kind of accepts it, including the physiotherapy and the hospital management, and they have put in the investment. and the peripheral supporters, the GPs, the basic what we call primary care service, they are prescribed
so
to
still you are going for the 100% for the ERAS protocol?
Precisely, yeah,
Okay,
yeah,
perfect.
yeah.
So anyone else has any different comments?
It's
Same?
it's not possible in the everywhere and every hospital.
Okay.
Because it must be done, that protocol, in the special type of the hospital, special type of the center.
Okay. So get this protocol followed for simultaneous bilateral arthroplasty? Mr. Tahir Khan, now, you have said yes, so you have to answer it.
So I don't do bilateral knee replacements, and bilateral hip replacements, I don't think anybody does it. So I guess it is applicable. I know my knee arthroplasty colleagues use it all the time, so I'm sure it's applicable.
So, sir.
Yes,
it can be followed for the ERAS protocol for the bilateral simultaneous? Yes. You think? Yes?
Yes.
Mr. Surel?
Definitely.
Sir, what's your support? So still.
If the centers is doing it for one, can do it for both.
Okay,
yeah?
perfect. So now this is the case, Mr. Tahir Khan. This is a 55-year-old male with a gardener. His socioeconomic is very poor. Now presented to us. His financially severely burdened. It's very hard to do stage. What do you say? Is it you will still go for the ERAS protocol for this patient?
I guess so. I mean, why not?
So in one day, if you can do the surgery and send the patient back,
I mean,
what about the physiotherapy exercise? How are you going to deal with it? So it is like easy for you to do simultaneous with the all pain management and everything?
What I'm saying, I don't do knee replacements, but I think if it was being done in UK, in RNOH, Royal National Orthopaedic Hospital, he will be enrolled for it, but the expectation would be not as much as for somebody who's coming for a uni.
So, no. Any one of you against it?
No, you just got to define what your outcomes and expectations are. It's all about preoperative education, preparation, discharge planning. You can do that for this patient just like any other patient.
Okay.
He may not be discharged in 24, maybe 48 hours or 72. You've still produced a rapid flow through in the hospital system.
So this, what we did, simultaneous bilateral, but it was being done as our protocol. The patient stayed for 5 days, and both the knee was replaced, the metaphyseal sleeve was used, and this is the outcome that we were achieved 6 months down the line. Okay, so this is about about it, enhanced recovery after surgery protocol tend to produce better clinical outcome in the early post-operative period for total hip replacement and other joint registry.
Can I just add something to
Please.
that? The protocol also involves the anesthetist giving appropriate analgesia, posterior capsular blocks, rehab unit, a well-versed rehab. So it's a drill. It's like a drill. Everybody's got a role to play, and it's not entirely surgeon dependent.
Right.
So I think that's a key. So for example, my anesthetist would never give only gives non-barbiturate anesthesia. He doesn't give barbiturates at all to the patients. We put a lot of local anesthetic. I do anterior hip for primaries. The only patient in my group who went home same day was a dancer, professional dancer, started walking 2 hours after. Most patients, as soon as they recover from the anesthetic gases, they are up and about. The physios are ready to take them for a run, and that's the key. So, but if they have barbiturate anesthetics, then they don't get up. They are drowsy. So I think the anesthetist is a very important, if not the most important person, and pain management is the key.
Okay. So this is another burning question nowadays. Everyone is talking about robots and robots. So robot in knee and hip arthroplasty. Starting with Dr. Rami Sorel. Sir, what percentage of your practice there's a use of robot in knee and hip arthroplasty surgeries?
So for knee replacements, it's 100%. For hip replacements, it's 0%.
So same goes with the other 3 faculties?
Hip is 0 for me.
Okay.
Knee is 10 or 20%. I'm using robot.
So, Tahir Khan?
I don't use robots.
You always do robots? You don't use robots?
I'm not.
So,
but people in my unit do.
Okay.
I just don't.
Okay, so The next question. Do you agree it has better long-term outcome? Now the whole of the light is on Professor Ramisurel. Sir.
Depends on whether you want a subjective or an objective answer to that. So of course it has a better long-term outcome, that's why I use it. But the evidence to date that's published is still undetermined. In the Joint Registry of Australia, it is starting to come out with one of the robots and one of the knee implants that there is a difference when using the patella and the robot in survivorship at 6 years. So we're just starting to see that data, but it's still very early at the moment.
It's earlier. Mr. Tahir Khan, you are using the robot? So you can go first, please.
I agree there is no difference.
No difference.
In my hand.
Yeah, no, I would agree with that as well. The published evidence is not there, and I think the evidence is probably going to be after 10 years.
Okay.
The relevant evidence would be after 10 years. The 5-year evidence which came from Wrightington in the knees, there was no difference.
Okay, so the earlier outcome, it has some difference, but the late still has to come.
I
right?
think, yeah.
Okay. So, can it be used in every case, Professor Ramisurel?
Well, I said I use it in 100% of cases.
Okay,
so
yeah,
my
that's
answer would
what,
be yes.
let's go with 100%. Sir, you?
No, not.
No,
I
Tuzan?
don't think so.
Tahir Khan?
I suppose it can be used in every case, but it's expensive as well. I mean, if you're coming to the price, we talked about it a lot. I don't use it, I get away with it, but I guess in years to come, as Shahzad was saying, maybe in 10, 15 years' time, we're going to all have to use it, I guess. I don't know.
So I know Zaki Saab is not using it. So if you get the opportunity, you think you will be the robot user?
I would like you to use the robot. That is what I'm going to say. I think I'm not very well versed with the computerization of the robot, but the younger generation should adapt to use any technique which makes them better. That is what I would favor. So the answer is yes, if you have the opportunity to use the robot, and it is cost effective and does make a difference to the outcome to the patient, use it. I use you and the others. They act as robots. And
But I will not going to use in every case in our part of world. So
they are my navigators.
Now, the other part. This is a female, 55-year-old male, female, known case of I think rheumatoid arthritis. She is wheelchair bound for the last 5 years. So my question to Dr. Ramisurel, what does robot will going to do different as compared without doing the robot? So how your planning can change with the bone loss, valgifying, soft tissue release and everything? Sir.
So what you're asking me is, would I use a robot in this case, right?
No, you are using 100% of the cases.
Yeah, so I would use a robot in this
you,
case.
You will going to use the
Yes.
robot? So what's the difference?
And I have used robots in this case, and in fact, you know, we have a dichotomy in that the majority of my work is at a private hospital where it's 100% robot use. In the public hospital, I have access to a robot as well. And if I come in the morning and I have a complex case like this, I'll ask for the robot because it gives me a lot more information intraoperatively to make critical decisions, and I find it easier using the robot. So I would advocate, if you're going to use a robot, don't keep it just for complex cases. Use it in all cases so it becomes a second instrument for you. And that way, in complex cases, it's more useful.
Yes, I believe it. I would like to use robot in
You
this
will going to
case
use robot.
especially.
Mr. Tahir Khan?
Can I be slightly controversial? Because I think this particular case, in my opinion, the major issue is soft tissue realignment.
Yes, that's my point.
And I don't think the robot will help with that. But equally, I think once you've done the soft tissue corrections, robot may be able to give you a better idea on how much bone to cut and maybe save a bit of bone, which is going to be the key.
So my understanding, the soft tissue release, that will going to go with the bony cut. So it's not a separate entity that you can use with the robot. So you have to do a distal cut and then some soft tissue release, then the tibia cut, then the lateral release. So still robot is into play in this case?
So look, you're still going to do the soft tissue releases here. You're still going to do a fenestrated posterolateral release. You're going to take the PCL. It's still the standard, but you're using a high fidelity tool to give you information intraoperatively, to tell you, have you corrected it to mechanical alignment if that's what you're aiming for? Or if you're using an alignment philosophy of kinematic or inverse kinematic, then you can adjust your tibial tray, your femoral tray so that you're not aiming for HKA of 0, you're aiming maybe for 3 or 4 degrees of valgus, maybe do less soft tissue releases. I do use mechanical alignment. I'm prepared to do the soft tissue releases, and I find the robot just makes it easier intraoperatively to make those decisions.
Okay. So what about this case? This is a female known as the rheumatoid arthritis, presented from the other country with a sizzling gait. This she is walking with the help of a support, and this is the present condition. These are the X-rays that is present over here. So, Dr. Amisurel, still you are on report.
I could show you similar cases we've done, just like that.
Okay, perfect.
And yes, you'll get intraoperative feedback of what your cuts are, you'll validate your cuts, you'll make a decision on soft tissue releases where needed. Some of these are correctable. You may not have to do soft tissue releases, but
yes,
the majority I can see.
Important point, is it correctable or not? If it is not, I think so there will be some issues with the soft tissue release. If it is correctable, then your life is easy. So, this was the first female that was operated, again metaphysical. So how then this bone loss with the robot can help you to get the solve that problem? Robot with the bone loss, like that's what we have to use a metaphysical sleep. So, anyone?
Yeah.
So look, the robot's not it's not a magic tool.
Yeah.
It's just a tool that assists you in making decisions. But you've still got to go back to foundation principles of how to restore bone where it's lost. And you've made the right decisions here to go zone 2 fixation, zone 3 fixation. Those basic foundations you still have to have, as you do. But people see robot as a solution that will fix all problems. No, it's just another instrument. Yes, an expensive instrument, but nevertheless, an instrument gives you a lot of information intraoperatively to help with those decisions.
Okay. So, any other comment? Any different comment? Or we all go with the same?
Yeah, I agree with everything, but the only thing I was going to add really is that we're far away from the Star Trek era. I think robot to me is a very expensive goniometer at this moment in time.
So we have got another 5 minutes, so we have to wind it up. This is namaz time. So this is what the evidence says. Again, the same what we have. The early there is some benefit, but long term it still has to come. So this is the last we were going to talk about it. It's because of the spine. And we have discussed a lot today about the spine correlation. So my question, do you always screen your patient for the spinal issue or not?
Yes.
Yes? Raise your hand. Yes? Yes, sir? Again, perfect. So which spinal issue is a no-no for arthroplasty until the spinal issue is sorted? The same that we have talked about it? Anything else?
I normally want the spine to be sorted first.
Okay.
Yeah, I think somebody said that they'll do the hip first earlier on. In my practice, I don't.
So
I discussed with spine surgeon,
okay,
and we decide which one is first, and we can do it.
So a hip replacement is an easier operation and gives good outcomes. It is the operation of the century. So where possible, I'll do the hip, then send them the spine. But there are circumstances like if the patient has radicular pain transferred down the leg, anything that may leave them with symptoms post-operatively that they won't accept, then they go spine surgery first.
Professor Zaki, your last comment.
I would always discuss it with my spinal surgeon because I don't do spine myself. And if it has a radicular pain, yes, I would ask him to take care of that first because that will be a negative factor for the patient after the hip surgery. And it'll be difficult and add to morbidity. So yes, I will discuss it with my spinal surgeons. I don't do routine evaluations of every patient from my hip for spines, but maybe we should be doing that, and we'll look into that. But for some difficult cases, yes, I would always ask the spinal surgeon for an opinion.
We have,
there were some great examples shown in one of those presentations with ankylosing spondylitis, which you guys have here a lot more than we ever see. No question, that's got to be spine first.
Yes.
But the majority of spines I send away to the neurosurgeon or spine surgeon, they send back, say, do the hip first, we'll worry about it later.
So this is the evidence, which is a fixed or uncorrectable spinal deformity with Sajata imbalance. So we have to stop over here. Thank you very much, sir, for coming over here. So now we have a Jummah prayers, and we're going to proceed after the namaz. Thank you very much. I request Dr. Balli to please take the seat.
the chair, bombarding you with more announcements. So just to let you know that the registered delegates without their families are invited for lunch. Registration is now closed. And if there are any delegates who've not received their cards as yet, would they be able to contact Mr. Ali Qureshi? Again, lunch will be served at 1:40 p.m. I think we'd be able to manage the Jummah prayers around 1:20. It sounds like in the next 10 minutes, maybe we can move it to 1:25. But we're hoping that after lunch, which is 1:40 p.m., we see you all back at 2:20 p.m. Thank you.
Hello, testing on 3. Hello. Hello, testing. Ready? Out भी देख लिएगा इसके अपने पास. Hello, testing on 3, 3, 2, 1. Hello. 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 Hello, testing. Hello. 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 Hello, testing. Hello. 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 Ahmad, iPad भी लेकर आना. Hello. Hello. Hello, testing on 3, 3, 2, 1. Hello, hello. Hello, hello. Hello, testing on 3. Hello, hello. Hello. Hello, testing on 3. Hello, testing. Hello. Hello, testing on 3, 3, 2, 1. Hello, hello. Hello. Hello, hello. Hello, testing. Hello, hello. Hello, testing on 3, 3, 2, 1. Hello, hello. Hello, hello. Hello, testing. Hello, hello. Hello, testing on 3. Hello. Hello, testing on 3, 3, 2, 1. Hello, hello. Hello, hello. Hello, testing on 3, 3, 2, 1. Hello. Hello, hello. Hello. Hello, testing. Hello, hello. Hello, testing on 3. Hello, testing on 3. Hello. Hello, hello. Hello, testing on 3. Hello. 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 Hello, hello. 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 Hello, testing on 3, 3, 2, 1. Hello, hello. Hello, testing. Hello. नमाज किधर है? किधर शमदान में? ये शमदान तो उधर है ना? हेलो हेलो देखें बोले थोड़ा पीछे हो
Testing 1 3 sound check 1 2 testing इसको ना ऐसे नहीं हिट करना मैंने सेटिंग थोड़ी ना ये देखें आप देखें Testing 1 3 sound check 1 2 देखें भाई check 1 2 testing 1 3 sound check 1 2 testing 1 2 3 sound check 1 2 सही है पीछे हो गई बोल रहा हूँ मैं check 1 2 testing 1 3 sound check 1 2 check 1 2 testing
hello hello testing on 3 3 2 1 hello 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 testing hello hello
Check. 1, 2, 3. 3, 2, 1. Check.
الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد بسم الله الرحمن الرحيم قل هو الله أحد الله الرحمن الرحيم ولم يولد ولم لم يلد الله الصمد لم يلد ولم يولد ولم يكن له بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد ولم يكن له كفوا أحد. بسم الله